Ma'am, please start.
Good afternoon, everyone. Namaskar, and welcome to our monthly feast of academics. And in this month of November, we are again invited so many lovely youngsters to share with us what they have learned in their clinical practice in this last 1 month. And today we have an array of speakers. We have young Dr. Soumya with an expert, Dr. Nilima, and we have Dr. Shubhra, who's going to speak on orthodontics, and Dr. Soumya and Dr. Nilima are going to present a neurology case. And then we have young Shruti, who is daughter of our very good friend, Dr. Jayashree Monkar, and she's going to talk on pediatric endocrinology. So we have an array of topics today, and to end it all, we are going to end with Palghar epidemiology. So without taking up any more time, I welcome the speaker for today, young Dr. Soumya Alukuchi, who is going to present us a case. And for this case, they were helped by Dr. Nilima Narkhede, who is DNB and MRCP from UK, and also she's a DNB teacher at Shatabdi Hospital at Kandivali. So with this, can we mute Dr. Smita? Can we mute?
Yeah, done, ma'am, done.
So with this, we go on to our first case for today, and Dr. Soumya, kindly take over.
Thank you so much, ma'am.
Thank you, ma'am. Thank you for the warm introduction. Today, I'll start to share my screen now.
मेरा क्या दिख रहा है?
Yeah, hello.
Yes, ma'am.
Ma'am, you can try.
Yes, ma'am. So, is my screen visible to everybody?
Yes, kindly make it full screen, ma'am.
Yes, ma'am. A
Perfect.
very good afternoon to all the members of Palghar Academy of Pediatrics. So, today we are going to discuss an interesting central nervous system case.
Samay, Samay, 1 minute. Can you all hear me? Yeah, मला तुमचा आवाज नाही येत आहे. काय झालं?
Yes, sir, we can hear.
Yes, sir.
I am Dr. Joshi. I am observer. I am happy that we have begun in time and we already have 30 people here joining here. Good. Carry on, please. Thank you.
Thank you, sir. So, we are going to see an interesting CNS case for today. So, we had a 8-year-old female child who was born of non-consanguineous marriage, second in birth order, and she presented to us with complaints of loss of achieved milestones which were noticed since the last 12 to 15 months. She had achieved age-appropriate milestones until 7 years of age, but gradually, parents started noticing that there is difficulty in her walking, where she was walking with her stiff legs and she was walking on her toes. And subsequently, they also noticed there is lack of clarity in her speech also. While taking the other history, there was no history of vision or hearing loss, no history of convulsions, no history of scholastic backwardness or personality changes or behavioral changes. There was no history of any skin or hair changes. There is no history of any abnormal facial features also. So in past history, there is no history of any head trauma or prolonged ear infections or dog bite or measles. The immunization was appropriate for age, and there were no similar complaints in the family members. And the elder sibling was 16 years old, and she's studying in 10th standard with normal intelligence. So up till now, the chronological age of the child was 8 years, and developmental age was between 3 to 4 years. So the pointers from history are there was normal antenatal history, and the normal development was there up to 7 years of age. And later, milestones started regressing in terms of walking and speaking. There is gait disturbances, and also there is dysarthria. There is no history of convulsions. So, based on this history, the first thing came to our minds was neuroregressive disorders, like which was mostly involving white matter. Anthropometry was taken when her weight was 16 kg below third centile, height was 121 centimeters at 10th centile, and BMI was also below third centile. And we did not find any micro or megalencephaly. On general examination, the child was conscious, oriented, and she was following verbal commands. Her vitals were stable. There is no pallor or icterus or cyanosis, clubbing or lymphadenopathy. Her eyes are normal. There are no cave rings or cataracts. Her skin and hair also are normal. There are no dysmorphic features. There are no neurocutaneous markers seen in the child. So this is a photograph of the child taken with permission from the parents. And we did not find any dysmorphic facial features either. On central nervous system examination, the child was conscious, she was alert, and she was oriented to time, place, and person. Her immediate and long-term, short-term memory was good, but long-term memory couldn't be tested because there is lack of clarity in her speech. Her intelligence was average. Her speech was slurred, soft speech with lack of clarity, and it was understood only by the family members. She was walking with stiff legs, broad base, with there is a lot of toe walking, and cranial nerve examination was within normal limits. And when we did her motor system examinations, her posture when she was lying down was her knees were flexed because of the increased tone. And the tone was increased in all four limbs with clasp knife spasticity. The tone was increased more in lower limbs than in upper limbs. And the power was 3/5 in all four limbs. And reflexes, we found there are upgoing planters, and her deep tendon reflexes were brisk with ankle clonus. We did not find any involuntary movements in the child. Her sensory system examination was normal. There were no signs of meningeal irritation, and cerebellar signs were also normal. On systemic examination, her cardiovascular and respiratory systems are normal. There are no abnormalities. And parabdomen also, it is soft and there was no organomegaly found. So here I would like to have some inputs from the members where we can have a few differential diagnoses.
What about her mentation? She could understand everything, cognition, I mean.
Yes, ma'am. Her cognitive power was good. She was alert and she was responding to whatever we are asking her. But her speech was problematic. So only her parents understood what she was speaking, and they were translating it to us actually. So there is lack of clarity of speech. Otherwise, she was active, alert, and responding to comments.
And no headache, vomiting, and erased intracranial pressure.
No, ma'am. No signs of raised intracranial pressure. Nothing.
Because this looks like a very much like a periventricular leukomalacia, like we see in spastic diplegia in young children. So like a geminal matrix, agar hydrocephalus hai ya IVH hai, we see a periventricular leukomalacia. So this is very much like that. The only thing is slurred speech is more like a cerebellar sign because of dysarthria. So
Yes.
and you said very specifically there was no ataxia. So
There
here
was no.
looks like just pyramidal signs and dysarthria. So the other thing is whether it could be, of course, syrinx would have more of upper limb involvement rather than lower limb. That could come at this age. And another thing is whether tethering of the cord can be there. So these were some of the things that came to my mind, but
Yes,
especially, yeah,
So-
anybody else wants to say? So that toe walking is so specific for upper motor
Tone.
neuron
Yes, ma'am.
spasticity.
Yes, madam. Because of the spasticity, she was walking on her toes.
toes.
And
Yeah,
So
and even the bladder bowel.
she has gained continence of bladder bowel at the appropriate age, and now also there is no incontinence noticed by parents. Nothing. So, based on the features which are mild actually, and also there are walking was lost, and her speech also lost clarity. So we suspected neurodegenerative disorders because all her achieved milestones were regressed. So, and there is no history of conversion. So, our main diagnosis, first differential diagnosis was neurodegenerative disorder involving white matter. So we investigated, we did a routine investigation where a complete blood picture was showing only mild anemia. Her liver function and renal function tests were normal, and calcium was borderline, but ophthalmic examination, which was suggestive of mild optic atrophy. And we further did MRI brain with contrast, where we saw diffuse cerebellar as well as spontaneous atrophy along with inferior Vermeer atrophy. So here I can show like complete cerebellar atrophy with Vermeer atrophy here. So this is one feature which was found in MRI, and also there is volume loss involving both the basal ganglia with probable hypomyelination or dysmyelination in the peri and paraventricular white matter with volume loss of corpus callosum. So here we found this peri and paraventricular white matter hypomyelination or dysmyelination with thinning of the corpus callosum. So these are T1 weighted images. So MRI was showing until here. So based on the MRI findings, we could come down to a diagnosis where we could suspect a leukodystrophy. So we further did a genetic study, which was enhanced whole exome plus mitochondrial genome sequencing. So we in genetic studies, we found there is a heterogeneous missense variant in exon 4 of the TUBB4A gene on chromosome 19, where asparagine was replaced for aspartic acid at codon 249. So this resulted in the disease named hypomyelinating leukodystrophy 6. So it is a heterozygous disorder and it is inherited by autosomal dominant inheritance. And it is the variant which was detected was pathogenic, which means which is explaining the symptoms the patient is having. So this hypomyelinating leukodystrophy is it is caused by heterozygous mutations in the TUBB4A gene. So this disorder is characterized by onset in infancy or early childhood with delayed motor development and gait instability, followed by extrapyramidal and movement disorders such as dystonia, chorioathetosis, rigidity, opisthotonus, and oculogyric crisis, and progressive spastic tetraplegia, and ataxia, and more rarely seizures. Most patients have cognitive and speech delay, but some can function normally. So our child did not have all the symptoms, but we found there is dystonia and rigidity and progressive spastic tetraplegia, and there are no seizures as such. So these are the findings we found in our child. And brain MRI was showing a combination of hypomyelination and cerebellar cerebellar atrophy or disappearance of the putamen. So for this disorder, there is actually currently no cure available. Only symptomatic treatment can be given. So this was our case. I would like to have any questions if posed by me.
Let Nilima madam comment. So we
Yes,
can-
ma'am. Yes, ma'am.
Yes, ma'am.
Can you stop? Is there more for sharing? Or
This
that's
new
all?
approach to her disorders.
Okay, okay.
Hello.
Yeah. Please.
Yes, ma'am.
Yeah.
So
you-
about this, talking
I think
about
you can start sharing because then we'll be able to see Nilima.
Okay, ma'am.
Pallavi, can you pin Nilima, ma'am?
Yes, ma'am. Doing the same.
Yeah.
yes, ma'am.
Done.
Okay. Yeah.
So, ma'am, regarding about this case, which is particularly like being.
Can you put on your video, please? We can't see you, Nilima. Yeah.
Name of medical, name of activity nahi Vedanta College.
Yeah, Nilima. Nilima, you have to unmute yourself.
Yes, ma'am. Yeah. Yes, ma'am. About this case, like the approach which we the symptoms which we could analyze was that she was having progressive difficulty in walking with more of a dysarthric speech. That slurred component was little bit like we couldn't see much, but there was definitely a slurred component. So initially, clinically, we might be thought ki like cerebellar might be involved, but more of a white motor signs depending on even the clinical features. As she was having typical class-manized spasticity and brace reflexes. So more of a white matter because lower limb more involved compared to upper limb. And so, but that's what we like cerebellar was very involvement. So that's why we thought ki we should do whole exome plus mitochondria. So that was the whole idea that to go ahead with the genetic studies. No family history, absolutely normal child till 7 years of age, and then subsequently lost her milestones.
What is the prognosis?
Poor prognosis, ma'am, regarding because as such there is hardly few leukodystrophies where there is cure is available, but the hypomyelinating generally there is no cure, is only symptomatic treatment.
Does this also overlap with SSP? Although this child had no measles, but we know that even vaccination can cause
Yes,
SSP.
but here the main function was cognition was absolutely normal.
Yeah.
And that was the no seizure. So that was the like least under diagnosis.
And another thing is pandas. They say that post-streptococcal. So is that also a possibility?
But they would have typical our MRI pictures, which was here typical of hypomyelination. That was the on the MRI. MRI was quite characteristic in her case.
I see. And on MRI, it looks like a pretty advanced disease, although
yes, ma'am. Pretty advanced. Like even we can notice that this is involving white matter.
Yes.
And cerebellum.
Almost the whole cerebellum is lost.
Atrophied.
Yeah. Very nice, Soumya, of you to work this patient up so completely. And how have the parents taken it? How have they accepted the diagnosis?
Yes, ma'am. Initially, I counseled them. So initially reluctant or denial, but in 2-3 visits, they actually now accepted the diagnosis.
Thank you so much, Nilima. Anyone has any questions? Please unmute and ask. Does the observer have any questions? Archana, तुमचाच case आहे, so. Hemant, any observation?
No, great, fantastic.
Really nice. Thank you so much, Dr. Nilima, for sparing your valuable
Thank you, ma'am.
Being part of our webinar. We look forward to having you on more such webinars. And thank you, Soumya, for working this patient up in so much detail and making this PowerPoint presentation. Do you want to add further? You have some more. Please share the rest of it.
Yes, ma'am.
Just shared approach to neurodegenerative, she will carry on.
Yeah.
Yes, ma'am. So I'll be sharing my case with
the rest of your presentation.
So whenever we see a case like this, so we suspect a neurodegenerative disorder. So usually the hallmark of neurodegenerative disease is regression of milestones and progressive deterioration of the neurological function, along with the loss of speech, hearing, vision, or locomotion, which may or may not be associated with seizures or feeding difficulties or impairment of intellect. So neurodegenerative disorders are a group of heterogeneous disorders which result from specific genetic or biochemical defect or chronic viral infection or or involvement of toxic substances. So they involve both gray matter and white matter as well. So grossly classifying the neurodegenerative disorders, it can be inherited or acquired. In inherited neurodegenerative disorders, it can affect gray matter or white matter or both, or it can have focal manifestations involving different random parts of the brain. So basically, how we differentiate between white matter and gray matter neurodegenerative disorders is by its age of onset, rate of progression, and principal neurological findings. So in white matter diseases, they usually occur late in childhood and they may have megalencephaly, and seizures come very late and rare. And cognitive function is initially normal, and peripheral neuropathy wise, there will be early demyelination and spasticity is early and severe with absent or exaggerated reflexes. And cerebellar signs will be early and prominent. And fundal exam will show, it might show optic atrophy. And on EEG, there will be diffuse delta slowing. Whereas in gray matter disorders, they usually occur in infancy with associated microcephaly and early and severe seizures, and there will be progressive dementia, and her spasticity will be late. It occurs later and it is progressive, and reflexes can be normal or exaggerated. And cerebellar signs also appear late, and there will be the retinal degeneration on fundal examination, and EEG will show epileptic from discharges. In this child, actually, EEG is pending, ma'am. We are yet to do that. We are yet to convince it. And so, if the gray matter is involved, based on the anatomy of the brain, if the cortical gray matter is involved, we can divide the diagnosis into two, with storage disorder and without and non-storage neurodegenerative disorders. In storage associated neurodegenerative disorders, with hepatosplenomegaly, we have GM1 gangliosidosis, Sandoff disease, Niemann-Pick's disease, sialidosis, mucopolysaccharidosis, and Gaucher's disease will come under this category. And where there is no hepatosplenomegaly, like Tay-Sachs disease, Rett syndrome, neuronal spheroid lipofuscinosis, and Menkes kinky hair disease come under this category. And in cortical gray matter neurodegenerative disorder with no storage component, the acquired and genetic features will be there. In acquired, we can have subacute sclerosing panencephalitis and chronic HIV or progressive rubella encephalopathy. And gray matter disorders which are involving the cerebellum, Friedreich's ataxia and ataxia telangiectasia are both the diagnoses. And if they are involving the basal ganglia, Wilson's disease, dystonia muscularis, and Huntington's disease are the components of involvement of basal ganglia majorly. And when white matter is involved, it can be either hypomyelinating or dysmyelinating or demyelinating disorders. In hypomyelinating or dysmyelinating, it is probably leukodystrophies, and leukodystrophies with macrocephaly are Alexander and Canavan diseases. And with normal sized head, they can be metachromatic leukodystrophy or adrenoleukodystrophy. And with microcephaly, it can be Krabs disease. And white matter with severe demyelination, we can have multiple sclerosis, Schilder's disease, and Devick's disease. So when the white matter is involved, there is delayed acquisition of motor milestones or stagnation of motor development or frank regression of motor cycles. Any of the three can happen. In an infant or young child, delayed motor development is more common in the hypomyelinating disorders, whereas in motor regression is common in leukodystrophies with myelin destruction. So the features of white matter involvement will be spasticity, optic atrophy, ataxia, and peripheral neuropathies. So, and early involvement of corticospinal tracts resulting in a central pattern of weakness, upper motor signs such as spastic quadriparesis or spastic paraparesis. If deep gray nuclei are involved, they present with dystonia, chorea, or mixed movement disorder. Prominent loss of cerebellar volume presents with slowly progressive ataxia. And if the peripheral sensory neuropathy leading to altered proprioception and imbalance may contribute to alterations in gait, leading to a mixed cerebellar and or sensory ataxia. So based on the MRI findings, we can divide them into two groups with prominent T2 hyperintensity and prominent T1 hypointensity. Whereas the other group contains mild T2 hyperintensity in combination with T1 hyperintensity. So our MRI findings are falling into the second category where there is mild T2 hyperintensity in combination with T1 hyperintensity. So it's a very huge classification. So, but our child, she is fitting into hypomyelinating disorders with mild T2 hyperintensity and T1 hyperintensity with no typical peripheral nervous system involvement. And based on her genetic study, she is fitting into hypomyelination with atrophy of basal ganglia and cerebellum category, which is called also as HABC. So the management of the neurodegenerative disorders is directed towards the treatment of the underlying disorders, and it is mostly supportive. So we can there are treatable complications like feeding difficulties, gastroesophageal reflux, spasticity or drooling, skeletal deformities, and recurrent chest infections, or epilepsy, sleep disorders, or behavioral symptoms can be cured by supportive management. And it requires a multidisciplinary approach where pediatrics, neurologists, and geneticists and orthopedician and physiotherapist will work together. And the neurodegenerative disorders with specific treatment modality available are mitochondrial encephalopathies, Wilson's disease, Refsum's disease, Lesch-Nyhan syndrome, or Fabry's disease. And specific treatment modality like bone marrow transplantation are available for Krabbe's leukodystrophy, metachromatic leukodystrophy, or mucopolysaccharidosis. Or Menkes-Kinckey hair syndrome will have its treatment with copper sulfate. So thank you. Thank you for giving me the opportunity, ma'am.
Thank you so much, Soumya. Your presentation was very, very complete and you've made some lovely slides. You must have taken a lot of trouble over this. And Palghar Academy of Pediatrics thanks you for your presentation.
Thank you so
thank
much, ma'am.
Dr. Hemant and Archana Joshi for having such a wonderful youngster as your colleague. And yeah, Hemant Joshi. Yes, sir. तुमचा आवाज येत नाही नीट.
Unmute करा.
हा.
Yeah, I want to say something very simple and small. See, it's great to discuss cases which are not treatable, right? But let us all in our practice ensure that every baby who steps in our clinic gets a better brain than what baby has. Majority of us have black knuckles. We have B12 deficiencies and you need B12 for myelin. So ensure that everybody who puts step in our clinic gets B12 and they get it from curds. They get it only from non-veg milk, and curd has more than milk. So at least ask them to take curds. Possibly give them B12.
I would like to thank Nilima ma'am for her support in making the PPT possible. Thank you so much, ma'am.
Thank you. Thank you.
हेमंतचा फ्रीज झालंय. Thank you, Nilima ma'am, for
Thank you,
your
thank you,
help in
for giving us
making
the
this
opportunity.
presentation.
हेमंत सरांचा व्हॉइस नाही गेलाय मॅडम.
हो हो, व्हॉइस पण गेलाय आणि आता ते मला वाटतं नाहीयेत, दिसत पण नाहीयेत. ओके, डॉक्टर शुभ्रा आल्यात का? डॉक्टर शुभ्रा मला दिसत नाहीयेत का?
नाही मॅम, मलाही दिसत नाही ना. समजा वेगळ्या आयडीने लॉग इन असेल तर मॅम, कॅन यू प्लीज अनम्यूट युअर सेल्फ?
Dr. Shubhra, can you please unmute and start your presentation?
No, she is not there.
Okay, then I think we go to Dr. Shruti Monkar.
Shruti ma'am is there.
Yeah. So I'd like to introduce her. तिची CV हे लावता CV slide.
Yes ma'am.
Dr. Anuradha, can you please call Dr. Shubhra in the meantime?
हो मॅडम, मी कॉल केला होता, परत एकदा करते.
हा. Yeah, so I'd like to introduce young, dynamic Dr. Shruti Monkar, and she is. Can we go to the next page, please? She is a consultant pediatric endocrinologist and an adolescent endocrinologist. She is consultant pediatric and adolescent endocrinologist at Endo Nurture Clinic at Borivali. She is also practicing at Mahim and at Bombay Hospital in Mumbai. She visits Virar every Monday now. How wonderful is that? So close to us. She also visits Joshi Children's Hospital and Chirayu Children's Hospital at Palghar. So she's, yeah, further, she is assistant professor, Department of Pediatrics. She was in 20 to 21 at KEM Hospital, excellent. And she was also a professor in the Department of in the pediatrics department. So she has done her post graduation from Liverpool in UK, and her clinical experience in pediatric endocrinology is in diagnosis and management of patients with growth disorder in Jahangir Hospital in Pune, and in comprehensive multidisciplinary care clinics at Alder Hay Children's Hospital. So she has a very big curriculum vitae, and we are so privileged to have you, Shruti, and we would love to hear you. So please go ahead with your presentation.
Thank you so much for the kind introduction, Manu. Shall I share my screen?
Yes, please.
Is it visible on full screen?
Yes, it's visible. Approach to short stature, please. Yes.
Good evening, everyone. I would like to thank the Palghar Academy of Pediatrics for inviting me for this talk. My topic for today is approach to short stature. Over the next half an hour, 35 minutes, what we'll be covering is the physiology of growth, importance of growth monitoring, etiology and definitions of short stature, clinical approach based on history, anthropometry, and examination, relevant investigations, followed by the IAP guidelines flowchart on approach to short stature, the various treatment modalities available, and guidelines on when to refer to a pediatric endocrinologist. So as we know, growth is a continuous process starting right from conception, and most of it gets completed towards the end of puberty. The Karlberg's ICP model, that is the infancy, childhood, puberty model, is one of the famous models which has described different phases of growth and the primary governing factors for each phase.
Okay.
So these governing factors are important because the particular age at which a child presents would let us know about the etiology which is likely. I've also added a component of fetal growth here to complete the entire topic. So it is important to know that fetal growth is independent of growth hormone. So those with growth hormone deficiency would have a normal birth weight and length usually. Fetal growth is dependent upon maternal, placental, and fetal factors. So the important maternal factors are maternal nutrition and maternal illnesses. So in mothers with poorly controlled diabetes, it may lead to a baby with large gestational age, whereas those with chronic hypertension, which is affecting the placenta, or those with torch infections can lead to SGA babies. The placental factors are certain hormones which are produced by the placenta, that is human placental lactogen and epidermal growth factor, which are responsible for fetal growth. And the fetal hormones, namely insulin-like growth factor 1 and 2. Now, IGF-1 and 2 in utero are independent of growth hormone, whereas after the baby is born, production of these are dependent on growth hormone. Coming to the next phase, that is infancy. This is primarily governed by nutrition and also by thyroxine and Norman-Bold metabolism. The childhood phase is governed by growth hormone and thyroxine. So problems with these hormones may present in childhood.
Presentation खत्म हो गया.
It is also governed by nutrition, micronutrients, and mental health. The last phase is the pubertal phase, which is a phase of rapid growth. This is governed by sex steroids, estradiol, and testosterone. These hormones not only directly affect the growth plate, but they also affect and increase the production of growth hormone. So both these hormones are necessary for puberty, and also thyroxine and nutrition. We should also know that each of these phases is also affected by genetic factors, that is the genetic potential of growth for a child, and environmental factors, such as, for example, there may be seasonal patterns which are noted in growth, and also the psychosocial environment of the child is very important for growth. So while individual governing factors have been described, there is no strict compartmentalization. Like those with severe growth hormone deficiency may also present towards the end of infancy. But nevertheless, it is important to know the primary governing factors for each so that we know the etiology. So coming to the first phase of growth, extrauterine, that's infancy. This is a period of rapid growth. So the growth velocity in the first year of life is usually around 25 centimeters per year. Now, what we need to know here is that when a baby is born, the birth length is independent of the mid-parental height. It is not directly proportional to that. It is actually proportional to the womb size. So alignment to the genetic potential usually occurs over the first 2 years of life. So some children may show a slight catch-up growth, while some may show a slight catch-down growth to actually enter the genetic potential height centile. Next is the childhood phase, where the growth velocity in the second year is around 12 centimeters per year, followed by the third year, which is 6 centimeters. Thereafter, till the onset of puberty, the growth velocity, the height velocity is usually 4.5 to 5 centimeters per year. And children in this age group where the growth velocity is less than 4 would be considered an abnormal growth pattern. In boys, so this is usually not seen in girls, but there's a significant degree of prepubertal slowing to as low as 4 centimeters in year. And this is then followed by the pubertal growth spurt. Next, puberty is a phase of rapid growth. There is a gain in height of around 20 to 25 centimeters in girls over 2 to 2.5 years, and 25 to 30 centimeters in boys. So the important point here is that during puberty, there is an overall gain in roughly 1 foot height. Whereas if we consider the height of an adult male or female, roughly 5 feet, 5 inches or so. So out of those 5 feet, only 1 foot is contributed by puberty. So we need to know that if a child presents in infancy or childhood with short stature, we should not tell the patient that once they enter puberty, the height will increase. So whatever height is lost in infancy and childhood can never be regained completely in puberty. So the age at which the child presents with short stature needs to be taken seriously, and it should be acted upon at that time itself. The timing of growth spurt is important. In girls, growth spurt usually occurs earlier at a Tanner stage of 2 to 3, whereas in boys, it occurs in mid-puberty at Tanner stage of 3 to 4 years. Once girls attain menarche or boys develop facial hair, that marks the end of puberty, and there's barely 1% growth. That's around 5 centimeters growth left. So waiting till that stage, we will clearly miss the bus, and hence growth assessment is important right from the beginning. So why is growth monitoring important? First, it helps us to identify both under and over nutrition, even before it actually becomes visible and comes to the notice of the parents. It helps in early identification of endocrine and other disorders. It is useful for adult height prediction and deciding treatment strategies if needed. And most importantly, it is a very good tool for parental education. So with this, let's come to the etiology of short stature. Though there are multiple causes mentioned here and a lot of patients present with short stature, it is important to know that the endocrine causes form a very small proportion. Most patients will usually present with certain physiological causes or with malnutrition or chronic illnesses. So these are the things which need to be ruled out first. So the physiological causes include familial short stature, where the child is short compared to peers of his age, but he is normal for his family genetic potential. The second is constitutional delay in growth and puberty, also known as CDGP. In this, usually the onset of puberty and thereby the growth spurt, both are delayed, but the final height eventually is normal in these patients. Coming to the pathological causes, these are chronic malnutrition, chronic systemic illnesses, small for gestational age with failure to catch up, including both syndromic and non-syndromic causes of HEA, endocrine disorders like growth hormone deficiency, hypothyroidism, Cushing's syndrome, and pseudo-hypoparathyroidism. Use of medications like corticosteroids, methylphenidate, and chemotherapy. Craniospinal irradiation or intracranial trauma, tumors, or surgery. Basically anything that would affect the pituitary or the hypothalamus. Certain syndromes such as Downs, Turner, Noonan, Prader-Willi. Skeletal dysplasias, rickets, usually non-nutritional, hypophosphatemic rickets, and psychosocial short stature. Whatever doesn't fit into all these goes into the dustbin diagnosis of idiopathic short stature. So coming to how to elicit a history. First and foremost, it is of utmost importance to identify when short stature was first noticed by the parents. So here we must recall the infancy, childhood, puberty model because this will give us an idea about the etiology. So since infancy is primarily governed by nutrition, the likely causes of short stature in infancy would be nutritional, SGA, skeletal dysplasia, syndromic causes, and towards the end of infancy, familial short stature or CDGP may present. Childhood, chronic illnesses, nutrition, growth hormone deficiency, hypothyroidism, and puberty, conditions like Turner syndrome or other conditions with estradiol or testosterone deficiency. So in order to get this history, the leading questions that we can ask the parents are on comparison with peers, with either siblings or in comparison with other classmates, how is the child growing? So we could ask them, if the child is standing in the assembly line, how many children are shorter than the child? So the parents may also say that few months ago, my child was 10th in the line, but now he's 3rd in line. So then it gives us an idea that there is a significant decrease in the growth velocity in this child. Similarly, we can also ask about history of whether the child is outgrowing his clothes and shoes compared to the other sibling. And if there are any previous height and weight records, these are always welcome because it will give us an idea about the overall growth trajectory. The other important pointers on history are birth weight. Low birth weight could be seen in SGA and syndromic causes. Breech delivery has a cause-effect relation with growth hormone deficiency and multiple pituitary hormone deficiency. Neonatal hypoglycemia could be seen in SGAs, GHD, and cortisol deficiency. Prolonged neonatal jaundice, unconjugated, could be seen in congenital hypothyroidism. Conjugated could be seen in cortisol deficiency. Feeding difficulties in the newborn period may be seen in Prader-Willi and Russell-Silver syndrome. A thorough past medical and surgical history is important. Weight loss may be seen in chronic illnesses and diabetes mellitus. CNS symptoms could be suggestive of CNS tumors. Hyperphagia may be seen in Prader-Willi or in hypothalamo-pituitary tumors. A detailed dietary history is necessary to identify malnutrition. Similarly, a developmental history would give us an idea. It could be delayed in congenital hypothyroidism or certain syndromes. Bladder bowel history is important because certain conditions like hypothyroidism or celiac could present with constipation. Celiac disease could also present with persistent diarrhea, similar to malabsorption syndromes. Polyuria, polydipsia could be seen with CNS tumors, diabetes, or renal tubular acidosis. Another important history we need to elicit is the age of parental menarche, because the child would closely follow those patterns. So if maternal menarche was early, we can anticipate that the child's age of menarche would be 1 to 1.5 years earlier than the mother. Similarly, in the father, the age of shaving or the growth spurt is important. So in males who have had CDGP, they would say that usually they were short in school, but after that they suddenly had a growth spurt. So that is a pointer towards CDGP. Similarly, family history of short stature, not just in the parents, but in 3 successive generations should be asked for, whether there's anyone who is very short in the family. And also history of consanguinity and presence of any autoimmune conditions should be asked for. We should also get a general idea about what the social environment of the child is like, whether the child has been exposed to any kind of abuse, because this could lead to psychosocial short stature. Coming to the most important part of examination, that is anthropometry. In most conditions, a thorough plotting of height, weight, and mid-parental height, and also the BMI, would give away the diagnosis in almost 90% patients, and few investigations just to support or confirm your diagnosis. So in my patients, I generally prefer to plot the anthropometric parameters even before I start taking the history, because these will give you an idea about what focused history you need to ask the patient. So based on anthropometry, we need to answer 4 questions. The first is whether this child is short or not, whether he is short compared to peers of his age, or whether he is also short for his genetic potential. How severe is the height deficit? Is the growth velocity of this child normal? And whether it is proportionate or disproportionate short stature. So coming to the first step, how do we identify short stature? We need accurate measurement. Infants below 2 years should be measured on an infantometer, above 2 years on a stadiometer. The parent's height should also be measured. These should then be plotted on appropriate charts. So for 0 to 5-year children, the WHO 2006 growth charts. For 5 to 18, the IAP 2015 charts. There are also combined WHO IAP charts for 0 to 18 years, and also pediatrician-friendly charts, which have a quick mid-parental height and BMI calculator. So these are easily available on the IAP website, and I think everybody should stick to using these charts. And apart from plotting the current height and weight, if any previous records are available, then those should also be plotted. Coming to calculation of mid-parental height and the target height range. So MPH is calculated as the mother's height plus father's height minus 13 for girls plus 13 for boys divided by 2. So this magic number 13 is basically the difference in height between an adult male and an adult female. So once we calculate the mid-parental height, the target height range is plus minus 6 centimeters of the mid-parental height. Now, in a busy OPD practice, it's often difficult to sit and actually calculate or bring out a calculator and calculate. So for this reason, there are the IAP pediatrician-friendly charts where the MPH calculator tool is available. So if you look to the extreme right, let's take an example. Say if the father's height is 170 centimeters and the mother's height is 155, we just join these two heights with a line. And the point where it intersects the vertical pink line should be seen. So now if we're calculating the MPH for a girl child, you extrapolate from the point of intersection, you draw a horizontal line towards the mother's height. So that comes to around 156. So if this is a girl child, the mid-parental height would be 156. If this would have been a boy child, you extrapolate it horizontally to the left towards the father's height. So the MPH here for a boy would have been 169 centimeters. So this is a quick tool that can be used to save time. So once these parameters are plotted, the next thing is to decide whether this child is short or not. So there are 4 definitions of short stature. The first being that the child is below the 3rd centile, also equivalent to -2 standard deviations for age and sex. So make sure you use the proper gender-wise growth charts, pink for girls and blue for boys. Next is if the height of the child is 1.5 SB, that is 6 centimeters below the mid-parental height, or if there is a fall in the growth velocity below the 25th percentile, or if 2 major percentile lines are crossed over 6 months in younger children and 1 year in older children. So let's see these definitions with the help of examples. The first example is an 11-year-old boy. His height and weight are plotted, and also the mid-parental height. So if we see the height of this child, is it below the 3rd centile line? It's below the red line, so yes. So this would fall into the definition of short stature because he's below the 3rd centile. But now when you see his target height range, the vertical arrow on the corner of the chart, he is falling within the target height centiles. So while this child is short for the population, for children of his age, he is normal for his mid-parental height. So this is a classical example of familial short stature. Going to the next example on the right side, this is an 8.5-year-old boy. His height and weight are plotted. If we see the height, is it short stature? It's above the 3rd centile. So by that definition, it won't be short stature. But if you see in comparison with the mid-parental height range, in the target height range, his height is significantly lower compared to the target height range. So while this child may be normal for the population, he is short for his family genetic potential. So this also constitutes short stature. That is the reason MPH always needs to be plotted on the growth chart, because if that would not have been plotted, this child's growth parameter would have been taken as normal because he's above the 3rd centile. Coming to the next definition. So this is a girl whose height is available at 7, 8, and 9 years. If we see the growth chart on the left, we can see that the height at 7 years is on the 25th centile, but successively the height parameters are not going parallel along that same centile. There is a decrease in the centiles. That is, at 8 years, she's on the 10th centile, 9 years, she's on the 3rd centile. So there is progressive flattening of the growth curve, or there's crossing of 2 major centile lines, which again falls into the definition of short stature, because here it means that the growth velocity is progressively reducing. The similar thing plotted on the right side. These are the Indian growth velocity chart. It may not be practical to plot these each time in a busy OPD practice. So this probably could be left to the pediatric endocrinologist. But so on plotting the height velocity, so between 7 and 8 years, she has grown 4 centimeters. So height velocity between 7 and 8 years is 4 centimeters. If we plot that on the growth chart, it is seen that it is below the red line, the 25th centile line. So this also constitutes short stature. Moving on to the next question, how severe is the short stature? So the closer the height to the 3rd percentile line, the less severe is the short stature. So we can wait and watch and monitor the growth velocity in these patients. The farther away it is from the 3rd percentile line, more likely is it to be pathological short stature. So 80% of children whose height is below -3 standard deviation have pathological short stature, while 80% of those between -2 and -3 are likely to have a physiological cause. So if the height is just below the 3rd centile, if the growth velocity is normal, if the child is within the mid-parental height range, I think we can monitor this child for some time before coming to any conclusion. Whereas if the child is very much below the 3rd centile and target height range, then it's best to investigate or refer. Next, coming to growth velocity, we saw how to assess growth velocity on the height for age charts as well as on the growth velocity charts. So if the growth velocity is normal, then it is likely to be a normal variant of short stature, namely familial short stature, CDGP, idiopathic, or small for gestational age children. If growth velocity is reduced, it is likely to be pathological. So chronic illnesses, malnutrition, endocrine disorders. SGA again can come under either. It could have a normal or a reduced growth velocity, and syndromic causes. The next question to answer is whether the short stature is proportionate or disproportionate. So the standard values that we usually all know are at birth, the upper segment to lower segment ratio is 1.7. At 3 years, it's 1.3, 7 years, 1.1, and 18 years, 0.98. However, these are global values. If we see Indian data, the values are slightly different at younger ages. But the important thing here to note is, for example, if we see a 3-year-old child whose USLS ratio is 1.2 instead of 1.3, then that is not considered abnormal. It is considered abnormal only if the ratio is below the 3rd centile for that age or above the 97th centile. So we get an idea of this on the Indian body segment, body proportion charts, the ones which are shown on either side. Again, not very easy to plot in a busy OPD practice. So we could just take the measurements and that will still give us some idea of proportionate versus disproportionate short stature. So if the USLS ratio is less than the 3rd centile, it implies there's a short spine, and the possible causes are spondyloepiphyseal dysplasias and mucopolysaccharidosis. If it's more than 97th centile, it implies short limbs. So these are seen in achondroplasia, rickets, or long-standing hypothyroidism or psychosocial short stature. The next important concept is the weight age, height age, and chronological age. So basically what we need to find out here is the weight more affected in this child or is the height more affected in this child? So normally the weight age, height age, and chronological age should all be the same, but more often than not, that does not occur. So let's take an example here. So if we see the height and weight of this girl, both are on the 3rd centile. So to assess the height age, what we do is from the height that's plotted, you draw a horizontal line till it reaches the 50th centile line. And from there, you drop a vertical perpendicular. So that reaches 8, which means that the height of this child who is 10 years old is actually like an 8-year-old child. The same thing we do for the weight. So for the weight, it is coming to 6.5 years. So that means that here the weight is much more affected than the height. And in those cases, the likely causes of short stature are undernutrition, chronic illness, or SGA with failure to catch up. So even if we don't actually plot the height age and the weight age, even at a glance, if we see both are on the 3rd centile, it means that both are more or less affected. So the likely causes are the ones mentioned here. Moving on to the next example, if height is affected more than the weight, or in a short obese child, it should ring a bell that these could be endocrine causes, skeletal dysplasia, syndromes, or non-nutritional rickets. So if we take the first example, the weight of this child is on the 50th centile. whereas the height is below the third centile. So clearly the height is affected more than the weight. So it could be one of these causes mentioned. Similarly, coming to the second chart, the weight of this child is on the 97th centile. So if we plot the BMI, this child is most likely to be obese. But the height of this child is only on the 10th centile. So in nutritional obesity, the children are tall and obese. But if a child is short and obese, then always think of endocrine causes. Moving on to other pointers on examination. Bradycardia could be seen in hypothyroidism. Respiratory rate could be affected in heart disease, asthma, hormone errors of metabolism, and diabetes mellitus. Bony deformities in rickets, skeletal dysplasias, hypertension in adrenal excess states. The shape of the eyes could give us clues. Almond-shaped eyes in Prader-Willi, prominent deep-set eyes in growth hormone deficiency, ptosis or pseudotosis in Noonan and Turner. Midline defects like cleft palate could be seen in GHD and PHD. Neck examination is important because a goiter could be suggestive of hypothyroidism, webbed neck in Turner syndrome, acanthosis in obesity and Cushing syndrome. Any typical syndromic faces should be looked for. Small hands and feet are seen in growth hormone deficiency and Prader-Willi syndrome. Abdominal distension may be seen in malabsorption state. Vision abnormalities in CNS tumors, Bardet-Biedl syndrome, and multiple pituitary hormone deficiency. Micropenis or hypoplastic labia minora in GHD and PHD. Undescended testes in Noonan and Prader-Willi syndrome. And typical features of various syndromes should also be noted for, like in Turner, Cushing, Russell-Silver, growth hormone deficiency, or hypothyroidism. And secondly, any signs of physical abuse should be looked for, which will give an idea of psychosocial short stature. Always, always, always assess the sexual maturity rate. This is important because the age of pubertal onset is very widespread. In girls, it can range anywhere between 8 to 13 years, and in boys, 9 to 14 years. It gives us an idea about whether the puberty is normal or early or delayed. It helps us make growth assessment in relation to pubertal staging possible. So if there is a girl child with Tanner stage B2 or B3, we know that she's going to get the growth spurt now. And it can also provide an estimate of the remaining growth potential left and if any treatment is required. So coming to a few examples, this is a boy with a large forehead, triangular face, pointed chin. He has bilateral splenodactyly, and if you see carefully, his left hand is slightly bigger than the right, so there's some body asymmetry. So this is his birth weight was also low. He was small for gestational age. So this is a case of Russell-Silver syndrome. The next child was also short. He was disproportionately short and had clinical features of florid rickets. On examinations, he was found to have VDDR2. The third child presented with short stature. He was a short, stocky, muscular-looking boy with coarse faces, some amount of lipedema, and the striking feature was pseudohypertrophy of the calf muscles. He also had a goiter, which is not visible in the picture. So this was a boy with hypothyroidism. Next, this is a boy with classical growth hormone deficiency with a prominent forehead, a doll-like face, prominent eyes, depressed nasal bridge, protuberant abdomen. There is some suprapubic fat deposition and micropenis. The last patient is a girl with Turner syndrome with the typical eyes, webbed neck, cubitus valgus. If we see the fist, she has a short fourth and fifth metacarpal. So it's called a knuckle-knuckle dimple sign. And the same can be seen on the X-ray to the left. Next, coming to the investigations. The first and foremost important investigation is assessment of bone age. So we usually land up using the Tanner-Whitehouse method, which is considered to be more accurate. And here, 13 different epiphyses are rated based on their size, shape, and maturity. And this is then converted into the bone age. So the importance of this is that bone age is closely related to the SMR staging and puberty. It provides an estimate of remaining growth potential. It helps in adult height prediction. And normally the bone age is within plus minus 2 years of the chronological age. So if it is delayed or advanced beyond 2 years, then it is significant and requires assessment. And of course, this X-ray also provides insights into other disorders like features of rickets can be identified, short fourth metacarpal in Turner syndrome, and metaphyseal irregularities in skeletal dysplasia.
Shruti, just a query.
Yes,
Because
ma'am.
we used to normally consider the carpal bones as determinant
Yes,
of
that's
age.
one of the most inaccurate methods, unfortunately.
Because we used to always say that, these many carpals
Yes.
for this much age, but here everything except the carpal bones were marked.
Yes. So we are also developing another method which is similar to this, but instead of all these bones, we are using just 3 bones: the radius, the hamate, and the distal third metacarpal, distal third phalanx. So we've seen that this also is showing very close results to the Tanner-Whitehouse method. So in OPD practice, at least for screening, that could be used, but we're now validating it in disorders of growth. So it's been validated in normal children. Now in disorders of growth, we're validating it.
Okay.
So coming to 2 examples of how bone age is useful. So in the first examination, in the first growth chart, if we see the height of this boy is on the 3rd centile. But if I plot his bone age is delayed by around 2 years. So I know that, okay, we still have some time for him to grow. And this is most likely a case of constitutional delay in growth and puberty. Coming to the next example, if we see only the heights that are plotted, it gives us a false sense of well-being that, okay, this child is growing wonderfully. In fact, his height centile has also increased. But if we plot the bone age, we see that the bone age is significantly advanced. So it's likely that this boy at 6 years has developed precocious puberty, and hence the growth spurt is seen on the growth chart. But if we plot the bone age, which is very advanced, we know that his height is going to remain short. So that is the importance of having a bone age in addition to the growth chart. Coming to the investigations, the first tier investigations recommended are basically to screen for chronic illnesses. So apart from the bone age, we would ask for a CBC ESR, liver and renal function tests, venous blood gas, a calcium profile, anti-tissue transglutaminase for celiac disease, and thyroid function. So basically, while this is an exhaustive list, I would probably not do all tests in all patients. I would do focused investigations. For example, the next test, insulin-like growth factor, is a proxy of growth hormone secretion and also of nutrition. But it's an expensive test. It costs almost 3,000 rupees. So I would be wary of directly prescribing it to the patient. I would probably monitor the growth parameters, which will give me a better idea, and then do this test if necessary. And the last test, of course, is karyotype. So Turner syndrome should be ruled out in all girls with unexplained short stature. I'll show you why in the next slide. So even if all these tests are normal, but the child shows faltering growth curve, then certain advanced tests need to be done, namely the growth hormone stimulation test, an MRI brain with pituitary focus to look for any tumors, malformations, or a congenitally small pituitary, and genetic tests if needed. So why should a karyotype be done in all girls with unexplained short stature? So while we see this image to the left, where the typical features of Turner syndrome are seen, this girl who looks absolutely normal and has no other clinical features apart from short stature also lands up having Turner syndrome. So Turner syndrome clinical features show a wide spectrum, and we should not be missing any of these children and diagnosing them directly at puberty when nothing much can be done about their height. So hence the reason of doing karyotype if short stature is unexplained in girls. These are the IAP guidelines in a nutshell on how to approach short stature. So first and foremost, we need to exclude systemic causes, social causes, and small for gestational age. Once that has been excluded, take an overall look at the child and see if the child looks normal or abnormal. By abnormal, I mean, is the child looking either dysmorphic or disproportionate? So if any of these are there, look for signs of specific syndromes. If the child fits into a particular syndrome, it needs to be investigated in that direction. If not, look for body proportions. So if there is disproportionate short stature, short limbs and short spine would have different causes as mentioned. If the child overall looks normal, the next thing that you would assess is what is more affected, the weight or the height. If the weight is more affected, it points towards malnutrition or chronic diseases. If the height is affected, you see how severe is the short stature. Is it just between -2 to -3, or is it even below -3? So if the short stature is very severe, if the growth velocity is reduced, and if there is a delay in the bone age of more than 2 years, then the likely cause is endocrine. Whereas if the short stature is not severe, it's between -2 to -3, growth velocity seems okay, and the bone age is within 2 years, then this is likely a physiological cause such as familial short stature or constitutional delay in growth and puberty. Coming to the treatment modalities, there are various options available, but of course, not all patients require all treatments. In fact, most patients do not require treatment, and only with the first 2 points, there is a significant improvement in growth. So the first aim is improving nutrition. We should always stress on the importance of a balanced diet with a good calorie, protein intake, as well as intake of micronutrients. There are studies which have shown the role of iron, calcium, zinc, and vitamin D supplementation on the overall height. But I would still not recommend unscrupulous uses of these. Use them only if the patient is deficient or prone to deficiency. It is important to address underlying illnesses. So treatment of celiac disease with a gluten-free diet, or asthma with appropriate MDIs, or hypothyroidism with thyroxine supplementation usually results in good catch-up growth. In boys with CDGP who do not show signs of puberty beyond 15 years of age, we can give them a short course of low-dose testosterone to kickstart puberty and help in starting the growth spurt. Then in patients with precocious puberty, only when the final height is likely to be affected, we can consider using GnRH analogs. However, in those who have the onset of puberty at a normal age, do refrain from using any of these treatments because they will not lead to any improvement in the final height and will do more harm than good. The next is growth hormone therapy. It is a safe medication when used for the right causes in the right doses. So the licensed indications so far are growth hormone deficiency, small for gestational age with failure to catch up by 4 years. So if a baby who was born SGA is still below the 3rd centile at 4 years, then he is not likely to catch up in terms of height and hence would require growth hormone for the same. Turner syndrome, Noonan, Prader-Willi, and Strock's mutations are also indications for growth hormone therapy. Achondroplasia and idiopathic short stature. Next is aromatase inhibitors.
What about familial short stature?
So familial short stature is also included under the umbrella of idiopathic.
Okay.
And so growth hormone will show magical effects in places where it is deficient. In the other conditions, it does show an effect, but the effects are variable. So even in familial short stature, growth hormone does cause improvement, but the improvement will be much lesser compared to that in growth hormone deficiency. Then, so aromatase inhibitors are medicines which block the conversion of testosterone to estradiol, and estradiol is required for epiphyseal fusion. So these medicines can be used in boys to delay epiphyseal fusion. And last but rarely used is the elixir of limb lengthening surgery. This is very rarely used in patients with achondroplasia where growth hormone has not caused much growth. The actual treatment vosoritide is not yet available in India. So sometimes these patients do tend to go in for limb lengthening surgeries. These are IAP guidelines on when to refer to a pediatric endocrinologist. It's quite an extensive list, but essentially if the height or weight is below 3rd centile or above 97th centile for any age, if there is crossing of 2 major centile lines for height or weight, if the child is below or above the MPH height range, if there is absent weight gain for 2 to 3 months in infants, or in older children, if the BMI is above the 23rd equivalent, that is in overweight or obese children, in children with a low growth velocity, in girls with precocious puberty, that is appearance of secondary sexual characters before 8 years in girls or before 9 years in boys, or the other extreme, that's delayed puberty, which is no signs of puberty by 14 in girls and by 15 in boys. In those where puberty is arrested for more than 2 years. The other causes are, the other reasons for referral are micropenis, undescended testes, atypical genitalia, gynecomastia, menstrual irregularities, hirsutism, and children who have been exposed to craniospinal radiation or surgery for brain tumors. So I would like to conclude with these take-home messages that every child must have at least one height reading per 6 months. Height lost in infancy and childhood can never be gained completely during puberty. A systematic stepwise approach using growth charts supported with appropriate tests reduces the need and cost of investigations for reaching a diagnosis. Serial height measurement records are much more valuable than a single cross-sectional height measurement. Endocrine causes, though important, are not the commonest causes of short stature. More severe the height deficit, more likely is an endocrine or pathological cause. So in severe short stature, reduced growth velocity, short for mid-parental height, delayed or advanced bone age, there is a likely underlying pathological cause which needs referral. Thank you.
Thank you so much, Shruti, and everything was wonderful. One is you sound just like your mom. That's very, very sweet. Second, your presentation was, like you've been doing this for the last 10, 20 years. So it was
Thank you
so
so much for
fluid
the
and
kind words.
so, smooth. Third, you also gave us a lot of growth charts that is so important. And you've highlighted one thing that pediatricians should always do is do anthropometry and mark growth charts. That's the one thing we should do as pediatricians. It's our prime responsibility. So that was some of the things I noted. And thank you very much for this presentation. Does anyone have any questions or any queries? So just wanted to know, is in growth hormone deficiency, at what age should we start the growth hormone?
So it can be started as early as 4 years also.
I
The
see.
earlier the started, the better.
Yeah.
And of course, more severe the short stature, the response is much better.
Okay. And then would it be a lifetime of growth hormone?
So ideally, it would be growth hormone. So basically, growth hormone deficiency is a spectrum. Some have mild deficiency, some would have severe. So the ideal treatment would be to start at diagnosis at whatever age it's diagnosed and continue till growth is complete. Sometimes the axis needs to be tested again for growth hormone deficiency after growth is complete, because growth hormone also has an important effect on body composition. So sometimes after growth is complete, a tiny dose may need to be continued, but not all patients with GHD require it. So the ideal would be that much, but of course, growth hormone is not a very it's a very expensive medication.
Yes.
Particularly if the weight of the child, I mean, as the child grows, the weight is higher, the dose will increase. So with GHD, even intermittent therapy, Dr. Khadilkar sir has actually he has quite a lot of data on patients who have received intermittent therapy also, but who have still reached their the MPH range.
So it's a weekly injection?
So for growth hormone deficiency, initially they were daily injections, but now it has also been approved. It's an approved condition for weekly growth hormone injections also. The other indications for growth hormone are still not covered under the weekly growth hormone. So
Right.
there are trials which are still going on for that.
And in idiopathic short stature, at what age should we start?
Again, depending at what age the child presents, I think after 4 years it should be okay.
Okay.
But there is no particular age cutoff that is mentioned in books. So it depends on how severe the short stature is, so basically in conditions other than growth hormone deficiency, growth hormone is basically more for cosmetic use in those patients.
Correct.
But I mean, of course, it has a lot of psychological impact also,
Yes.
because the child has to stay with that height for a lifetime. So I think it depends on a lot of different factors taken together. Of course, the affordability of the patient also.
And
But
it-
like intermittent therapy works for GHD, that's not always the case for the other indications of growth hormone. So for them, continuous therapy is required at least for 3 to 4 years to show a good response.
And for SGA babies, after 4 years, you would start just like in.
Yes, so there are two different guidelines, the US guidelines and the UK guidelines. One says that you can start it you can start it as early as 2 years of age. The other one says 4. So I think for severe short stature, if they're below 3 SD at 2 years or below 2 SD at 4 years, then we could consider starting it.
Okay. So a lot of things are clarified.
Yes.
Reiterated that we have to monitor growth. So, thank you so much. And
Thank you so much,
regards
Vani.
to your mother as well.
Thank you.
Is Dr. Are we going to have the talk on maxillofacial surgery and things like that? Is Dr.
Shubhra
Shubhra?
is there. Shubhra ma'am
Yeah,
is-
hello. Yeah, I'm there.
Hi, Shubhra. Yeah.
Hi, dog. A very good
Yeah.
evening.
Very good
Yeah.
evening, and we were missing you for this while. And
I'm so sorry.
yeah, so can we have Pallavi? Can we have Dr. Shubhra's CV?
Yes, ma'am.
Right?
Yeah.
Yeah. So today I have the pleasure of introducing one more youngster who's going to talk to us about uh, all about the mouth and chewing and eating. And that's Dr. Shubhra Mogre. And she's a postgraduate from Chandigarh, and she's a master of dental surgery and orthodontics. And she has specialized in alignment, and she is I will not know what this Invisalign practitioner is, but in lingual orthodontics and in orofacial myotherapy, and she's also a certified implantologist. That's a lot of things that we don't know about, and we're looking forward to listening to you about this, Shubhra. So please go ahead.
Thanks a lot for the kind introduction, ma'am. I would need some permission for sharing the screen.
Pallavi?
Is it visible?
Yes, ma'am. Permission is given.
Yeah. Okay.
Yeah.
Hi,
Go
everyone.
ahead. We can see you. Your slides are visible.
Yeah, hi, everyone. I am Shubhra. I'll start with, yeah. So I welcome you all, pediatricians, and with this presentation, I aim to give you an overview about orofacial form and functions and enable you to start diagnosing orofacial dysfunctions. So my aim here is to inspire you and start looking at faces and smiles. The index, how we are going to go about this presentation. So I'm going to talk a little about myself. Then I'm going to share the why, what, and how of orofacial dysfunction. Then I'll share a few cases and a takeaway message. So I have done my graduation from PGI Rohtak, and I have done my post-graduation in orthodontics and orofacial orthopedics from PGI Chandigarh. Right now, I have a clinic, Smile Specialist, along with my husband, who's a pediatric dentist, Dr. Saumil Mogre. We run the practice in Virar, West area. So orofacial form and functions, this is what we're going to discuss now. So I recently started with this book, and let's start with why. Why are we going to do this? So this is my practice, orthodontics and dentofacial orthopedics. So orthodontics is related to movement of teeth, and dentofacial orthopedics is related to the jaws. Now I have my practice overlapping with ENTs who treat nose, pulmonologists who treat trunks, and pediatric dentists who treat kids' teeth. Now there is enough evidence that orofacial dysfunction does lead to malocclusion, that is the abnormality of the positioning of the teeth. Now there is an effect of malocclusion on the self-esteem. Also, it not just the esteem, it also may be a reason of obstructive sleep apnea later in age. And the treatments for the treatment of malocclusion, that is maxillary skeletal expansion or anything, they have a very important effect on the upper airway. Also, the very early orthodontic treatment does benefit the patients in a very long run. So this is where you come in. So you lie at the heart of my practice because you can actually identify, you're the first point of contact with the patient, with the child, and you share a very special bond with the kids. Then you can help in early identification of growth problems, which you can see in your regular practice. And being at the heart, you can be one of the most important, one important part of this interdisciplinary approach of treatment that should be done for kids with orofacial dysfunction. Coming on to what is orofacial dysfunction. So orofacial form is whatever gives the shape to the jaw and face. That includes the bone, teeth, muscles, and overlying soft tissue. Orofacial functions are the functions that we perform from that is chewing, swallowing, speech, expression, etc. So according to the functional matrix theory, the growth of both upper and lower jaw are dependent on the functions that they perform. So here the orofacial function is important for the growth of the jaws. So it is not specifically the form or the functions we are interested in. It is the interplay between the forms and the functions that we have to focus on. During growth, the orofacial functions guide the growth of the orofacial form, while in adulthood, the form guides the functions. So it is a two-way street for
kids. Now let's have a brief overview of the orofacial forms. So this is the jaw, this is the face. It basically consists of maxilla, which is a paired bone. Matlab there are two bones joined in the middle, and mandible, which is an unpaired bone. The maxilla has upper teeth and the mandible has lower teeth. Next comes the, so this is the upper part of the jaw. This is called palate. The palate has two halves. So whenever required, we can actually open this suture up and we can expand the palate. These are the muscles, the tongue, and etc. Other are the muscles of the cheek. So I would like you to put special emphasis on this muscle, buccinator. Then are the muscles of facial expressions. So there is something called buccinator mechanism. What it states is that the muscle in the center, that is tongue, it equilibrates the pressure of all the surrounding muscles, that is buccinator, superior constrictor, and the muscles of upper and lower lip. So there is an equilibrium between these two muscles. If the equilibrium is disturbed, then there will be changes. You can see certain changes because of this disturbance in the muscle. Next, coming on to the orofacial functions. What is the normal orofacial function? So in a normal individual, the tongue should always lie on the palate. It should be sticking to the palate. The breathing should occur through nose, and the teeth should be slightly in contact. This is the normal orofacial function. Now, during swallowing, the tip of the tongue should touch the palate and the food should be taken inside. This is the normal function. Now, what is the dysfunction? So a dysfunction is when anything from this is disturbed. Tongue may leave the palate. The patient might start breathing through the mouth. In cases of thumb sucking or finger sucking, the mouth opens, the thumb lies on the palate, and this all leads to the dysfunction. Okay. So whenever there is a dysfunction, the equilibrium is disturbed, the buccinator mechanism is disturbed, and we see the consequences of disturbance in the buccinator mechanism. Now let's see how a normal face looks like. Okay, in a normal face, what all you have to see. So first you have to see the shape of the face, how it looks like. The first is it looks like a squarish face. The lips are together when the patient is at rest. The smile is broad enough. There is a good shape of the chin. The throat form is straight, and the teeth are straight both horizontally and vertically. So this is how a normal face looks like. Now let's see how a normal smile looks like. A normal smile should have straight teeth. The upper teeth should be overlapping the lower teeth, and there should be a good smile arc. The good smile arc means the curve of the upper teeth should follow the lower lip. This is a good smile arc. Now let's see how a normal inside the teeth look like in a normal individual. So the shape of the arches should be U-shape. The teeth should be arranged in the form of this arc, both upper and lower. The upper teeth should be in front of the lower teeth. That is known as the overjet. Okay, and the upper teeth should overlap the lower teeth by certain extent. Usually it is 2 millimeter. In kids, up to 50% is considered normal. So I have read this book, The Checklist Manifesto, and it says that if you have a checklist of things, it is easier, and there is a chance that you will not miss a few things. So this is one thing that I would mention here, that these are the 14 points that I've taken out for you, so that you can see these 14 points in every patient. I would request everyone to take a screenshot or a photo of the picture, and you can start observing these points in your patients. When I go through the cases, we will be seeing all these points in all the cases, so that we know how to identify an orofacial dysfunction and how to identify if there is a problem with the orofacial form. Now let's compare. Okay, so now on the right is a patient who has some orofacial problems. So the patient is a mouth breather. The patient has an open mouth posture most of the times. The patient cannot sleep properly. So these are the problems that the patient has. Now let's see what all other features that we can see. If you see the shape of the face is long and narrow. It is not square. Lips, although they are together, but you see a puckered chin appearance. So there is something here. You can see the patient is deliberately closing the jaw, closing the lips. The chin, let's see how the chin is. So the chin does not have that beautiful shape. It is kind of flat. The throat angle as well as slanting. Right? Let's see the teeth. So the teeth are not that straight, only 2 teeth are visible in the front, and the rest of the teeth are not even visible. Let's see the teeth from the side. So they are inclined forward. They are inclined a bit forward in the teeth. So these are the features that you can identify in a patient having a problem with orofacial form as well. To summarize, patient has a long and narrow face, puckered chin or a golf ball appearance, then the chin is flat, throat is slanted, teeth are not horizontally straight, and teeth are not vertically straight. Let's look at the smile of this patient. So do you see what's the width of the smile? So the smile is narrow. You can see these triangular area on the side of the smile. These are called black triangles. So black triangles are visible. The teeth are not straight and the arc is not even visible. Let's get into the jaw of a patient. What kind of jaw can you see? So if you see the shape of the arch, it is kind of V shape. The arrangement of the teeth is not along the curve. There is no space for all the teeth. You can see crowding in the anterior region. Let's see the overjet and overbite. So there is a little increase in the overjet. The front teeth are a little in front of the lower teeth. And the overbite is not that much. It is just 1 to 2 mm, which is a bit less for this patient. You can also see the change in the jaws here, right here. So there is a kind of a curved kind of structure for this anterior. So the anterior portion is, there is a problem. So right now I'll take you to a video that explains how mouth breathing is affecting the jaws. Can you hear it? Can you hear this?
No, there is no sound.
Yeah, I think there is something wrong with this.
Structures inside the nasal.
Can you see that?
In
Can you
that
hear the
way,
sound?
you're to your nasal and oral tubes. Your throat is not going to heavily affect the lymphoid tissue in the adenoids and tonsils, which is the last area to catch harmful particles.
There is an echo.
Before it gets resolved.
Yeah, there is an echo. Yeah, there is some. Okay, I can. The echo has come right now.
Someone has two devices connected.
Ma'am have to stop one device audio, ma'am.
Shubhra, you will have to stop one.
Yeah, I'm checking. Actually, I had stopped the. Is it better? Okay, I'll share the link from this video. So this video
Yeah.
explains how the mouth breathing affects the upper jaw. The
So
same
we
thing
can
that we
hear,
have read.
can we see it without the sound?
Yeah, I think yes. Yes, that we can do. So I'll explain. So when the patient does the mouth breathing, the adenoids and the tonsils are the first line of defense against, and this leads to the overgrowth of tissues and the patient is not able to breathe. It leads to lowering of the tongue that disturbs the equilibrium of the upper jaw, the Buxton-Whittle mechanism that we see, and it leads to ideally it should be touching the palate. Now, if it is not happening, if the tongue goes down, the maxilla constricts that we had seen in the photographs as well. So this is the Buxton-Whittle mechanism happening and constricting the upper jaw.
So in that child, the mouth breathing came first and then the facial abnormality.
Yeah, so it is it is said that orofacial dysfunction, the functional problems should precede the orofacial form. Now, if the patient started mouth breathing, the reason might be the nose. See, the patient is not able to breathe the nose, he starts mouth breathing. It is not always the mouth breathing as a culprit. So it's like a chicken and egg problem that we do not know which came first. But then if there is a dysfunction, then we can see the problem in form. So the dysfunction has to exist for certain duration for the problem to occur.
Correct.
Now, why the mouth breathing came? It might be because of the nose. It might be just a habit. It might be because of the anatomy of the patient. So there are three different reasons why a mouth breathing can occur. But what we can do is identify the reason and correct the mouth breathing.
Correct.
Okay. I think this is clear. So I'll take you to a brief timeline of how the growth takes place. So the growth of the cranium finishes by 6 to 7 years. The growth of the upper jaw is largely completed at 8 to 10 years. For the growth of lower jaw, there is a wider range, so 11 to 14 years. The growth of lips, that is soft tissue, continues from 15 to 16 years, and the changes in soft tissue continues for a lifetime. Now, why this timeline is important? If there is something wrong with the upper jaw, we'll have to treat them early. If there is wrong with the lower jaw, we can treat them a little later. So the growth of lower jaw coincides with the adolescent growth curve. So that is how you can have an idea how the growth of jaws is occurring. This is another video. I would not take you to the video. I'll share the link with you. Now, this is a video about a patient aged 11 years and 12 years. At the 11 years, orofacial dysfunction was identified in the patient. So the patient started biting the lip like this. And we did tell them that there is a problem, but then they did not do anything and the problem continued. What I wanted to show is the changes in the airway, the changes in a few other things. So you see here, the chin is good, the throat is good, everything is nice, but here the chin went deep. This is called, this is a mental circus came, and the throat also slanted. What is very significant is a change in the airway. The airway here is a very, very broad, and here it is constricted because the whole of the lower jaw got pushed backwards. So this is one example, and this is a real case, and we could actually compare the two sets, and we could find that there is a abnormality. So the orofacial, if there is a problem with the lips or breathing or the tongue, then it does create a issue in the orofacial forms. Now, I'd like to take you to the cases, and in these cases, we are going to identify how to identify changes in the orofacial form and how to modify forms for a better function. Okay, so my idea here is to train your mind so that your eyes can pick up the cues. So this is going to be a bit intensive. I would like everybody to buckle up and see how we're going to go. Okay. Yeah, so in the cases, I'm going to take you to mixed dentition cases. That is the case when the permanent teeth and some baby teeth are present. So the treatment usually takes in 3 phases. The initial phase, we correct something. In the resting phase, we let the growth take its own phase. And the final treatment, we correct all the things. That is usually done by braces. And these are the expansion cases when we expand the jaw, class 1 cases, class 2, distalization, tongue tie, and 2 other cases. Okay. So this is the first case, and we are going to see everything in the form of the checklist that I have given you. Let's see the shape of the face. And I'll be a bit quick because there are a lot to share. So the shape of the face is a bit squarish. This is fine. Lips are together at rest. The chin seems okay, not that bad. The throat form seems okay. Let's see the teeth. The teeth are not really straight horizontally and vertically. So there is something wrong with the teeth here. Let's focus on the smile. Is the width good? No. There are some black triangles on the side. The width is not good. The teeth are not straight. The arc is not consonant. So there is something wrong. So we know there is something wrong. Now let's see the teeth. What is wrong? So the upper jaw has gone inside the lower jaw. What is the shape of the arches? It is fine, okay, a little U. The arrangement of teeth is along the curve. So these are baby teeth. These are the remnants of baby teeth present, because of which the permanent teeth have come back. The decay in the baby teeth is the main reason why the permanent teeth do not come in a proper position. This is where pediatric dentists come in. They should prefer giving these crowns so that the width of the tooth is always there. Now let's see the overjet. Is there an overjet? No, there's no overjet because the upper teeth have gone inside. There's no overjet. There is no overbite. This is known as underbite. This is proper overbite. This is underbite when the lower teeth come ahead. So we have understood the cases. I'll show you the progress. This is how we treated this case. We did the maxillary expansion. This is a appliance called Hyrax, and we were able to bring the front teeth up in front of the upper teeth in front of the lower teeth. This is the change in the chin. We are happy with the change in the chin. So overall, with the treatment, we could expand the upper jaw. We could make some space for the teeth. Now down here, we would let the growth takes its own time, and we would treat when the lower jaw growth comes in. Let's see another. This we have seen the case. Again, just a little review for you. So the face is a little vertical rectangle. The lips are together, but there is a puckered appearance. Chin is flat. Throat form is slanting. The teeth are not okay. The teeth are not okay vertically or horizontally. The width is not fine. The teeth are not fine, and the arc is not consonant. The shape of the arch is a V. Arrangement is not proper. Little overjet and overbite. Let's see how we treat this case. So we did an expansion. Now this is an appliance known as MSC, maxillary skeletal expander. And now we would let this jaw grow on its own. After this, we will take out the appliance and we will let the lower jaw respond accordingly. Now this is another case. Let's see, what is the width of the arch, which seems okay, not so bad. The teeth, there is one little teeth which is above. Apart from that, everything seems okay, right? Now let's see the jaw. Now the shape of the arches looks okay, arrangement looks fine. It feels that there is space, but if you see the lower jaw, there is no space for all the teeth. Now see the overjet. Now there is the catch that the overjet is increased. When the overjet is increased, it means that the lower jaw is a bit behind. Okay, the upper jaw is in front and the lower jaw is behind. Now this lower jaw, when the lower jaw is behind, it also takes a lot of space from the airway. Now this patient came with a complaint of sleep disorder breathing, that the child is not able to breathe properly. He wakes up many times. He's not feeling like himself. He's not performing well in studies. So these were the complaints that the patient came with, along with the complaint that the lower teeth are not aligned. So what we did for the case, again, we did an expansion for the case. We expanded the upper arch using an MSC, and we were able to give a broad arch to the patient. When there is a broad arch, the tongue can stick to the palate and the normal function can happen. So if you see the overjet, here the overjet is this much, and here we could reduce it a little bit. So the lower jaw came forward. When the lower jaw comes forward, it relieves the airway and there is the extra space for the patient to breathe. This is the activation schedule of this appliance, this expander that we are talking about. It opens up from the middle. So if you see, these are the two ends, and now these are the two ends. So this expander opens up. This is the activation schedule, how many turns it goes. It is typically the 14th turn when the maxilla breaks open. I'll show you the CBCT images of this appliance. So this is an implant-supported appliance that goes directly to the bone. It engages both the cortical plates, that is known as bicortical engagement, and it opens up the airway. Can you see? This is how it is opened up. The expansion is nearly parallel. So if you see, this is one half of the maxilla, this is another half of the maxilla. Here we had seen there is a suture, and the suture has been broken open. So the airway does not increase only the mouth as well as the nasal airway. So we have been able to increase the airway in the sagittal direction, in the sagittal, and as well as in the horizontal direction. So this appliance is really good when the patient has a breathing difficulty. So there are studies that not just the maxilla, it also opens up from these sutures. So there are studies, and I have not got into that. So this is a patient who's very happy. The snoring and the sleep problems have gone with this appliance. After this, we are going to wait for the lower jaw to take its own course of time. Okay, now this is a patient not with a breathing difficulty, but with just a teeth issue. Let's see, how's the shape of the face? Now, these points I'm repeating again and again so that you can actually incorporate into your practice. First, shape of the jaw. It's very easy. So first you have to see the shape of the jaw. Then you have to go to the lips. Then you have to go to the chin. Then you have to see the throat. And because I'm a dentist at heart, you have to see the teeth as well. So the shape looks okay. Lips are little open at rest, little open, which is not good because when the teeth are open, then the patient might start breathing through mouth. Chin seems okay, throat seems okay, teeth horizontally are not okay, and the teeth vertically are also not okay. See the smile? There are some dark triangles in the sides. It means the teeth are not broad enough. Teeth are not okay, arch is not consonant, right? Let's see the arch. It seems like a V shape. There is not enough space, there is not enough space for the teeth. How's the overjet? Overjet seems okay, overbite seems a little less, but okay. Again, if you see, there is this curve, dental yellow curve, which is present. Now let's see how we treated this case. We treated this case with expansion and braces. Now this is a case for which we have a good follow-up. Now you can see how it goes by. So if the patient comes in young age, so we treat the maxilla, we expand the maxilla. If you see here, the maxilla is expanded, the lower jaw is still narrow. If you give enough time, so this is after 3 years, this is after 2 years, the mandible also expanded on its own. We did not do anything, just orofacial myotherapy, normal tongue positioning, normal breathing, etc. And it grew on its own. Then there were just little rotations and everything had to be corrected, that we corrected by braces. Can be done easily. So this is how the treatment for this case went. So the patient is happy. She came with the chief complaint of zigzag teeth, and her mother was treated with extractions, means taking out teeth for arranging the other teeth, which the mother did not want for a child, and we could do that. Okay. Another case, this is not really a child, but I just wanted to show that even if there is this much uh, crowding, that I call it, it can be relieved by simple expansion appliance. This is an expansion appliance, follow up of the cases. Good arrangement of teeth could be achieved in this case as well. So the whole idea of expansion therapy is to achieve good maxillary dimensions, the dimensions of the upper jaw, and then give a chance to the mandible to catch up. This is done by orofacial therapy to include all the functions of tongue and lip together, and then align the teeth later on with braces. Next, we'll see the class 2 cases. Now, what is class 2? When the maxilla lies in front of the mandible. Okay, this is class 2. What is class 3? The mandible lies in front of the maxilla. This is roughly what is class 2 and what is class 3. My cursor is not working that good. So this is a patient. Let's start from our checklist. How is the face? This is a little vertical. Lips are together at rest, not a problem. Chin. Now here is a catch. In class 2 cases, the chin will always be behind. So that is how you identify a class 2 patient, that the chin would be behind the upper jaw. Teeth look good vertically and horizontally. The smile looks perfect. There is no problem with the arches, look perfect. But the catch here is the overjet. Now the overjet here is around 8 mm. Okay. Overbite is a little deep, but still. So there is just one feature that you will be able to identify in a class 2 sometimes, that is the overjet. Now this is how we treated the case. Now see how could we change the chin. So from here to here, we could achieve a good positioning of the mandible. We treated the patient with this appliance. This is called a twin block appliance. This is before treatment with the appliance, after treatment. This is a retention plate. After retention, a little tooth abnormality was there. It was little outside, so we gave another phase of the treatment, and then no braces were used. We did this case only with function appliances. So good positioning of the mandible was achieved, good function was achieved. That was an amazing case. Now let's look at the other case. What is the shape of the jaw? Shape looks okay, squarish. Lips are okay, together at rest. Chin looks a little behind again. The class 2 case, the chin will always be behind. Then throat angle looks okay. Teeth are not okay horizontally. Teeth are not okay vertically. So it is a teeth issue if you see. Now this case, if you see, these are the little teeth which are not letting the lower jaw to go in front. It is just kind of blocking it. So this is where the problem started. These little teeth come at the age of 9 years, say 8-9 years, and from 9 years the jaw is not growing. This is why the patient developed into class 2. So if we can identify this early, we could have corrected it. We could have just corrected it and the jaw would have grown on its own. We do not want to treat it at all. So this is how the treatment went for us. Here the basic thing is the overjet. What we have to see is the overjet. Overjet is 10 mm basically, which is too high. So overjet is the reason we had to treat this patient, and she felt that her upper jaw was in front. In fact, the lower jaw was behind and not the upper jaw. So this is how the treatment went. Very good. Chin was, we could get a good growth of the chin. This was treated by a fixed function appliance. This is one of the ways a function appliance is given along with the braces, and we could attain good overjet. Now, this case had a problem, had a complaint of forwardly placed upper jaw. These cases always come with the problem of forwardly placed upper jaw instead of backwardly placed lower jaw. So you have to identify how these are. This is another case. Shape looks okay, lips look okay, chin looks fine, but it's still behind. The chin is still behind because it's a class 2 case. The teeth are not okay horizontally and vertically. Let's see. Now, in the previous case, there were little side teeth. These are called lateral incisors. Now, in this case, the central incisors, the central 2 teeth are buckled backwards. This is known as backwardly placed teeth or retroclined teeth. Now, the teeth are not like this. The teeth are like this, which is preventing the lower jaw from growing forwards. Again, this case also, if treated during early age, this problem would not have occurred. This is how we treated this case with braces again. So chin a little forward, we could take the chin. But taking the chin forward is always a matter of growth. So we need to have growth if we need to take the chin forward. This is how we finish this case. Again, good overjet and overbite could be achieved. Now, this patient came with a problem of irregular teeth, obviously, because the front teeth were buckled backwards. Now, I'm just giving you an example that these cases can also be treated by extraction, means taking out, knocking out 2 teeth. So if you see there are 2 of premolars, here is 1. But when you do the extraction, the shape of the jaw, a little bit constriction is there. See, in the other case, we did this case with extraction. So when the patient crosses a certain age, we cannot do expansion, we cannot let the mandible go ahead, and then we have to extract. So early treatment warrants omission of extraction. So that is where the early treatment helps. Now this is a patient with a severe abnormality because 1 tooth was missing in her arch and she led to this. Now this we treated her in 16 age, and even after achieving a very good occlusion, very nice teeth, there was a little, see, can you see there is a little slanting still remaining. We could not correct it 100%. So the little things do remain if we try to treat the cases later on. So the aim of class 2 treatment is to prepare the maxillary arch so that the mandible can come forward. Okay, so this is how we treat class 2 cases. Now, class 2 cases, because it is a question of mandible, we can take up these cases at the age of 11 to 13 years. Now, we are going to talk about class 3 cases. Now, class 3 cases is when the maxilla, the upper jaw, is behind the lower jaw. Now, the growth of maxilla completes by 8 to 10 years, so we have to hurry up in treatment of the class 3 cases. Let's see. How's the face? The face looks squarish. The lips look okay. So this is a cleft lip case. You can identify there is a scar in the lip. The chin, now here, the class 3 cases, because the chin is, the mandible is in front of the maxilla. So the lip will have some protrusion. If you see, so the lip is little protruded outwards. This is a sign you can identify in a class 3 patient. So the teeth are not really visible. We cannot comment. Look at the shape of the arches. Here, the arrangement is not proper. There is not enough space because there is a scar tissue. It is not really a growth problem. This is a problem where the scar tissue stops the growth of the maxilla. So we have to act early and we have to treat this. So there is an underjet, there is a negative overjet, negative overbite. Underjet and underbite. How we treat these cases? This is what we could achieve with face mask therapy and see a little change in the chin we could achieve. Now, how we treated is we gave a face mask therapy in which we opened the upper jaw and we pulled the upper jaw in front. And after that, we could achieve a positive overjet, positive overbite, and then we started with the braces treatment for arrangement. This case is still going on. So we could, so class 3 is upper teeth inside the lower teeth, and the reason is the palatal scar tissue. We cannot really do anything about it, so treatment is the only thing that can help the patients with. Now, our next case, this is also a class 3 case. Shape looks okay, teeth look okay, chin looks a little ahead of the maxilla. Then the teeth horizontally, can you see the teeth here? Here there is something wrong here, and there is a negative space. So there is a black triangle present. The width is not okay, the teeth are not okay, the arch is not consonant, nothing is okay. Let's see the shape of the teeth here. So you see these 2 canines are upwards, they are lower. See, there is not, the overjet and overbite is just enough, and the arrangement is not okay. The shape of the arch, though it is a U shape, but then there is a crowding in upper and lower teeth. This is how we treated this case. We did an expansion in the upper jaw, and we are still treating the lower jaw. This is near completion. I don't have recent photographs, otherwise I would have shown this. I'm just going to debone it like the next month. So this is how we could treat this case. This is the expansion. After the expansion, we did put the braces and we could align it. So the class 3 cases also, the class 3 cases all are basically because of the maxillary less growth of the maxilla. So we have to take up these cases early and we have to follow them up for a longer period of time because we have to see how the mandible is growing. Again, the position of the tongue and airway has to be taken into consideration. Next case, shape of the face looks okay. She is a little broad, so this is vertically, a little vertical component is there. Lips seem okay. Again, the lip is, the chin is a little in front. You can identify this from the chin appearance only. The teeth do not look horizontally and vertically okay. Let's see the smile. Can you see the lower teeth are in front of the upper teeth? So only 2 teeth are in front of the upper teeth. Now, if you see inside, this is how it is. Okay, so the shape of the arch is little box shape, and the arrangement is not okay. There is not enough space for all the teeth. There is no overjet. The overjet is negative. The overbite is also negative. So this is how we identify this is a problem. This is how we treated the case. We did the expansion. So I'll show you how this, and we could achieve a little change in the shape of the chin. So this is how we treat such cases. Once we do the expansion, then this expansion device creates a midline diastema. Then we leave it for some time. It closes on its own around 1 month of age. It takes around 1 month to close on its own, and after that we remove the appliance. This is how the progress of the case went. Again, this now the patient had come because lower teeth were in front of the upper teeth, and she was told by dentists that she would need surgery, which is not required at this age. At this age, we have corrected it. Now, we will have to follow up this case for the mandible growth, and if required, we'll have to do something. So, class A treatment is basically an early treatment in which we try to expand and protract the maxilla. Protraction of the maxilla means taking the maxilla in front so that the lower jaw growth has to be monitored. Now, coming on to the distalization cases, what does it mean? It means that when the upper teeth is okay, lower teeth is okay, and there is just crowding, so we can actually push these teeth back. This is known as distalization. Now, in these cases, there may be additional abnormality that we'll have to check. So this is one case. If you see the upper and lower teeth, they both look forward. They both look forward. So this is a case of distalization because we want to take both of them backward. So here one very important thing, I've put this case because I wanted to show you one specific thing. Shape of the arches is V, both upper and lower. The arrangement looks okay, not so bad. We do not know if the space is not okay. That just looks fine to a person who's just seen the teeth. Now let's see the overjet. We have been talking upper teeth in front of the lower teeth, but it is not only for the anterior teeth, it is also for the posterior teeth. Now you see this area. If you see this area, then the upper teeth are inside the lower teeth, right? The upper teeth are inside the lower teeth. So this is known as crossbite of the posterior region. So this is a posterior crossbite. Whenever there is a posterior crossbite, you have to treat anytime it occurs. If it is 1-year-old child, you have to treat. So crossbites are not good because it stops the growth of the maxilla. And because maxilla grows early, you have to take care of that. So this is how we have planned the treatment of this case. This is a recent case. Now this is a big appliance. And I'll show you what is this appliance. So this appliance has this screw which is going to expand, and these two screws are going to distalize. So the expansion phase is over here. Now the distalization phase has started. It will take around 6 months to distalize. So this is going on. So we could achieve the expansion of the jaw. Now we are taking back the distalization. I'm just showing you an advanced thing. So this is a 3D printed device. This is a metal printed device. Again, the function is to distalize. With these appliances, we can distalize. So this is kind of a hi-fi device. There is no space for the canines. There's no space for the canines to come. So we are going to distalize the molars, then the premolars, and we are going to gain space for the canines. Because the arch length, the width of the arch was okay, we thought about the distalization. Next, I'm going to talk about the impaction. Now, what is impaction? Now, when there is not enough space in the jaws, the teeth do not come out sometimes. So let's see how an impacted case is treated. We create space and we bring out the teeth. As simple as that. Let's see one case which has impaction. Starting with the checklist. The face looks okay, squarish, lips are together. Yes, chin looks okay, not a big deal. Throat looks a little slanting, but fine. Teeth horizontally, do you see good teeth? No, it doesn't look good. Vertically also, the teeth do not look fine. On smile, there is kind of a zigzag. There seems to be a crossbite between these two teeth and these two teeth. So there is something wrong with this arch. Okay, now let's see. So there is no space for these canines. The shape of the arch is kind of V for the upper arch, U for the lower arch. Arrangement of teeth is not okay. There is no space for all the teeth. Overjet seems okay. Overbite is a little less, but okay. Now, this is the problem in this patient, that the lower canine has not come into the arch and it is deviated. Now, this has happened because of the loss of the space. So it is not just the upper jaw, it is the lower jaw also when the teeth go haphazard. So this less space occurred during the time this bud was forming and it got shifted, and now it has developed into a vertical direction. Let's see the progress of the case. We had an expansion to create space for the upper teeth and to create space for the lower teeth. This is where we are today. And we still have to disinfect, but there is enough space. Now the teeth can come. There is enough space for the upper teeth. We are able to align all the teeth in the upper jaw, and we are waiting for the lower disinfection to happen. Again, the patient had come with a complaint of crowded upper teeth, but she also had sleep disorder breathing, which has gone now. The patient's mother is very happy that my child can sleep properly. We are yet to disinfect this tooth. Another case, now this is a problem of tongue thrusting. What is tongue thrusting? Is when the tongue starts pushing the teeth out. So this is a typical case of tongue thrusting. When it occurs in childhood, then it might also lead to the impaction. Now, in this case, there is the permanent canines are missing. 3 of the permanent canines are missing. So this canine is somewhere upwards. It is entangled in the roots of the teeth. The lower canines are in the center. So we have been able to disinfect 2 of these teeth. One tooth is still remaining. I do not have recent photographs. I'm just trying to show you how less space can lead to disinfection. This is another case. There is no space in the jaw here. So this is why the tooth took a roll and it is like vertical in the jaw. So this is one of the ways in which the less space affects the jaws. This is a patient, this is an adult patient, this is not a child, but this is a patient of tongue thrusting. I'm just showing how it is treated. We can actually close the spaces, but even after closure of the spaces, we need to train the tongue. The tongue has to be trained so that it does not keep pushing the teeth outside. So tongue training, orofacial myotherapy is the heart of this treatment with tongue thrusting. And the disinfection of all the teeth is very easy in early age. So if you see this patient is still in the mixed dentition phase, only 2-3 upper teeth have come. So this is an ideal time for the disinfection so that we can create space. The treatment plan would be, again, expansion of the jaws and trying to bring out the upper incisor. And later on, we'll leave the mandible to grow on its own. Another case of tongue tie. This is a patient with a moderate tongue tie. It is not that severe. Now he had a speech difficulty. His jaws are perfectly okay. His jaws are not a problem here. Tongue tie patients do have a jaw problem, but this case did not have. So this is kind of a different thing for us. But then he had speech difficulties. He was not able to speak fast, and certain words he could not speak. So we did lingual phrenectomy using lasers. We have our own lasers, and this is done by me. This is why I'm presenting this case. Ideally, Dr. Somal Mugre does these phrenectomy cases because that's his forte, but then I could do this case. Not just the tongue, he also had this frenum attached, because of which there was a space in the upper teeth. So we could take care of that frenum also. And ultimately, the patient could touch the tongue to the upper jaw. This is how I see how, because this is the function that we're trying to achieve, right? The tongue should touch the upper jaw, so he could do that. Another case of phrenectomy. Now this is a severe phrenectomy. Tongue tie. This is a severe tongue tie, and this case was treated by Dr. Somal, but still I'm showing it, taking the lower teeth. Now this is a biosimulation done by lasers for tongue tie. So tongue tie release is important in cases when the patient is having some difficulty. I'm not saying treat all the tongue ties, but then there are a lot of difficulties that come with the tongue tie. That's Dr. Somal's topic to discuss. Next, how early should we treat? As I told you, as early as possible. Now, this child did not come for the treatment. This child was just playing in my waiting area, and I just saw this. So ideally, what happens is these little kids, 1 year age, the chin is really behind. It is protruded somewhere here. So his chin was a little out, and he actually, when I opened the mouth, he had a crossbite of the front teeth. Now there are just 4 teeth. You might see it's not a problem, but this is a very severe problem, and this is a very easy problem to correct. So if you see the inclination of these 2 teeth are different. So they are a bit behind. So these 2 teeth are a bit behind the surrounding teeth. So what we did is we gave him a tongue finger pressure therapy. So we asked the mother to just press little, and this was corrected in 1 week. This could correct in 1 week. We did not need any appliance. We did not need anything, no expansion, nothing. Just tongue pressure could correct it because the child was 1 year of age. We have a follow-up of 5 years now. The child is 5 years of age, and this is how his arches are. Now, this is what is a good growth. His teeth are better than teeth of my own son. So what is the shape of the arch? Shape of the arch is U-shape, which is very important. Arrangement of teeth looks good. Spacing. Now, when there is a kids' teeth, the baby teeth, milk teeth, they should always have spacing. Unless and until there is space, it means the maxilla is not growing properly, the mandible is not growing properly. Typically, this space increases. If you see a child, typically this space between the lateral incisor and the canine in the upper jaw, that increases with time. It means the maxilla is growing properly. So if you have little practice like this, then you can see there should always be spacing in the jaws. Now, follow-up of this case has gone really nice. Now, this is how the jaw should not be. If you see this case, then you would find that there is something wrong with this case. So the shape of arches is fine. It seems like a U. Arrangement looks okay. Now, if you see, whenever you see decay, what happens is this part of the tooth is gone. So what happens is the tooth drifts forward. It creates a disturbance. Now, this is what is called an open bite. There is no bite. If you see, the maxilla is inside the mandible. So this is possibly whatever can be wrong is wrong with the jaws. And there is this shape of the dentoalveolar component. So whenever you see this, it means that this needs to be treated. Sadly, this child is a dancer and the patient and the parents think that she does not need treatment. Anyways, but that should be treated early. Now I'm going to show last two cases of why we should treat early. Now this is a case at 23 years of age, she came to me for correction of crossbite. Can you see this canine is in crossbite and this incisor is in slightly crossbite? We could correct it properly. The jaw was also okay. Not very ideal, but we could achieve. In certain less, when the problem is less intensive, we can actually correct it. Now let's see another case. So this case came with an underbite of this. So the lower whole bite has gone into the crossbite. And there is a jaw deformity associated with it. These are the scans. I could not get the photographs. We have our in-house aligner setup. So we make our own aligners. This is why I could get you the scans. This patient is being treated with aligners. These are transparent rays along with I've given an elastic also for correction of the jaw deformity. So from here to here, we could come here. Now the jaw deformity is still there, even though we have been able to correct overjet and overbite. So this is how the case looks today. And it has been, I think, 7 months we're treating this case. And if you see, there is still some jaw deformity, and this cannot be corrected at this age now. We would need a surgical intervention to correct it completely. And if this case would have been 11 years of age, I can guarantee that complete treatment would have been provided. So summarizing, the early treatment is the key. We have to identify which portion of the jaw is not okay, and accordingly, we have to decide what we have to do. Now, I'll give you a very important way of treating, way of going ahead is how can you identify? So I have given you a checklist of 14 points, just revising it for you. For the face, you have to see the shape, you have to see the lips, chin, throat. For a smile, you have to see the width, you have to see how the teeth are, if the arch is okay. And for teeth, you have to see the shape, arrangement, overjet, and overbite. So if you can look at it, it will be nothing like it. You will be able to identify the problem in a quick go. Now, while talking to the patient, it is said that the diagnosis starts the moment the patient enters the practice, and that is very, very true. The patients of mouth breathing, if you say they have their chin a little upwards and they'll walk loud like, so they always have a mouth open, and unless and until you ask them on anything, they would have an open mouth, jaw tilted upwards. You can actually identify the posture of a patient. You can see if the patient thrusts the tongue, they will be talking like that. The tongue will always hit the teeth. You can see that. You should find how the patient is breathing. So there is a very specific way the mouth breathers talk. So mouth breathers talk very fast because they don't have to wait for breathing through nose. They breathe through, and you would see this sound every time they're talking. So while talking, you can actually find out if the patient is breathing through the nose or through the mouth. Nose breathers always take a quick second to breathe through the nose. They stick the tongue on the palate, and that is how they breathe. So even while talking, you can make your diagnosis. Patients with speech difficulties also may have jaw problems. Or you can ask, what you can ask is about the open mouth posture from the parents, how the child sits, how the child sleeps. If it is an open mouth posture, quality of the sleep. If the child is not sleeping soundly, then there might be an issue with the airway and frequent nasal blockages as well as sinusitis. So I'd like to close with this remark that with great power comes the great responsibilities. And the choice of being a hero is not really a game, it's a fate. And you lie at the heart of it. You actually are in a position that you can give a gift of breath to your patients. It would be incomplete to say thanks to my patients. These are little young patients and they're very close to my heart. My practice would not be the same without them. So, gratitude for my patients and thanks a lot for your patience.
Fantastic, Shubhra. You walked us through so many patients, which I feel now I've been seeing every day. So
Oh, yeah.
yeah, so many of them, and so many of them, you just feel ki we had a girl who had such a huge, protuberant mandible, and we sent her very reluctantly to the dentist, and he said that she needed surgery. So that reiterates what you said, that start early and start soon. So at least we should start diagnosing them very early. And it was a wonderful presentation. So many things can be done, and you showed all of them without extracting a single tooth, because
Yeah, yes.
my own son had 4 teeth extracted because his upper jaw, he had a cross bite and so many things, and it took so long.
So, yeah, so you know how a crossbite is and how
Very
it goes.
painful.
So only in the early ages we can do that. Even I do extractions, but then there are patients who are way ahead in the growth. So that is where it lies. And crossbites should be treated as and when you see them. So you see, I showed a case of 1 year as well. We treated a crossbite. So that's where the diagnosis is very, very important, and that's where you lie at the heart of all the practice because you see the patient so often, and with that special relationship with the patients you share.
Absolutely. Absolutely, Shubhra. And it was a wonderful eye-opener. So, a shout out to all of our pediatrician colleagues that please look into the mouth and don't just look at the tonsils, and look at the teeth, look at the shape of the face, and look at so many other things that she has told us. And surely, Shubhra, we will be looking out for all of that. And thank you very much. And Archana, you
I
want
would be ready to take up any questions if you have.
Proud of you, Shubhra. Wow, great.
And thanks a lot, Ram. Thanks a lot.
And you have a wonderful smile. So
Yeah.
Thank you. So a lot of patients do come in and say that we would like a smile like
smile
yours,
like yours.
and I do try to give that, and that is the reason why I take photographs of my patients and show them. See, your smile is little equally like me. So
So
that's the
nice.
way we go about it.
Wonderful.
Now just notice how well she has taken her cover back, the background and her appearance and everything. She's so meticulous about everything what she did. हम लोग ऐसे ही बैठ के present कर देते हैं कैसे भी,
Nay,
है ना?
and all your cases, your presentation was so good. Everything you have taken care of. So, did you make this presentation just for us?
So we do keep a record of all the patients. So I had it in my, but then I arranged it for you. I had to choose what cases I wanted to show to what
Fantastic.
extent. And because we take a long follow-up, sometimes some cases are missing, the pre-treatment photos are gone. So we try a lot to do in this case. But yes, I tried a platform called Genilia something, and I always try to learn new things. So I tried one platform for animations and everything. But then yes, I use a lot of things for making
Each
this.
of
But
your
I
each of
really
your
wanted to
case-
make it count for you so that you understand how effectively you can actually go through the things. This is why I took some time out and found out. It took me a lot of understanding to see how to present it in a way that you can take it ahead. It is not just me showing how I treat cases, but also for you to identify how to see, what to see, and you train your mind so that now your eyes can be able to see what is wrong.
Exactly. So you have each of your presentation, each of your case had at least 8 or 10 photographs. So in this
Yeah.
angle and that angle and inside the mouth and upper jaw and lower jaw. So the take-home messages for all of us pediatricians is, do look out for those who are mouth breathing. Do look out for those who have an abnormal shape of the face and who have abnormal, jaw closure, open mouth, open bite, a cross bite, and do refer them early. So I think because it not only matters cosmetically, but it also matters how they breathe, their airway is affected, as well as mouth breather will always have dental caries and other problems as well.
Right.
And every tooth is important because she showed us how 2 decayed teeth, caused overcrowding and caused a problem. So there is a lot inside the mouth we need to see. So thanks a lot, Shubhra. That was an excellent presentation.
Thank you. I'd like to thank Dr. Shruti. Okay, so I have a question here I'd like to take up that somebody has asked dental treatment for sleep apnea. So sleep apnea is a very complex thing. So what happens is the airway collapses during sleep, as simply placed. Now we have to find out the etiology. Why is it happening first, and what all can be done about it. So the role of ENT is very important here. What if the airway is somewhere blocked? Now talking about the dental treatment, so we have appliances which places the mandible up in front so that the airway is relieved at the back. Expansion is also one of the treatments that does solve. I have quoted it in the very starting that there is a very good evidence that the MSC treatment that I do in a lot of my patients that expands the upper jaw, it expands the airway, and it does help with the obstructive sleep apnea. But again, yes, the etiology is a factor. The other thing that we do is a maxillomandibular surgery. Now, what we do is we place both the maxilla and the mandible forward if that is the reason for creation of less space at the back. So for obstructive sleep apnea, see, I have cases who cannot sleep properly. We do ask them for polysomnography, but a problem is there that the whole team is not there. See, I work with in PGI Chandigarh, so the idea of treatment there was an interdisciplinary treatment. We used to work with surgeons, we used to work with ENTs, we used to work with pediatric dentists, and there was a team. So because you have raised this question, I would like to present it like we can make a team because we all are working together and we all can work together for our patients. It is not just one specialty that can treat an obstructive sleep apnea patient. It will need a lot of efforts. Sometimes when the patient is on CPAP therapy or PPAP therapy, they are also treatments. Then sometimes patients want to switch on to the other. So it needs an interdisciplinary treatment. And if I can, I would like to have a team, and I would like to help make a team in which we can start treating patients, not just sleep apnea patients, the other patients as well, because it needs the care from all the specialists. It is not just me. As I showed you, the interdisciplinary team has an ENT, pediatric dentist, and pediatricians and pulmonologists all working together as a team for the benefit of the patient.
Dr. Jayashree has asked, what are orofacial exercises?
So orofacial exercises are aimed at bringing back the normalies. Now you have to see if there is a tongue tie, then you need to do tongue exercises. I'll give you a quick help with this. What is the best tongue exercise is you touch the tongue on the palate. I'll just bring the mic closer. You touch the tongue on the palate and then you make a sound like this. Oh. This is one little exercise that helps. Even I play this game with my son every day without fail. So that this is one tongue exercise. And then if the lip is a issue, like in class 2 division 1 cases, when there is a big overjet, the upper lip becomes hypotonic, means it doesn't start, it just becomes non-functional. So you have to do the lip exercises. In cases we do this sphincterectomy, we give these type of exercises so that the freedom does not attach. So orofacial exercises are exercises of the orofacial muscles, and that is aimed to bring back the normalies. So my treatment always includes some kind of exercises so that the patient breathes properly. One most important thing I'll bring back to your notice is the patients with mouth breathing are also chest breathers. They stop breathing through their diaphragm somehow. So what I do, I ask my patients to put a hand on the tummy.
फ्रीज झाले वाटतं त्यांचं.
हो, ऐकू येत नाहीये.
The video has also stopped.
Some exercises like this I give for breathing exercises, but then we have to identify what is the problem, and then accordingly they give the exercises. But that does help. And my whole treatment, see, if I expand a jaw, I have created a space. Now the patient has to breathe through the nose. If he still breathes through the mouth, then the treatment is of no use. So we have to adjunct the treatment with exercises so that the normal function is restored. So mouth breathing, if the patient has, we give them breathing exercises, tongue exercises, lip exercises, so that the normal function can be achieved.
Good.
Shubhra, there are a lot of compliments for you on the chat. And
Yeah, thanks a lot. I would like to share the two. I had to share the two links. I'll just wait for a second so that you can copy as well. So I'll share it.
if you can share it with Dr. Anuradha or Dr. Jayshree,
Huh. Yes,
yeah, then she
yes.
will
I'll
share it
share
with
with
all
Dr.
of
Radha
us.
so we can share. So one is the mouth breathing effects, and one is from our YouTube channel of our clinic, how the change in the face took place for a patient who started having orofacial dysfunction. So that is a little we try to keep our patients updated about things. Anything
Excellent.
else?
Excellent. Dr. Hemant Joshi, काय बोलायचं आहे? Anuradha?
Overjoyed. I'll just share one experience.
Yes.
My grandchild is now 8 years old. He was born in UK and he had small tongue tie. He was seen by their pediatricians. Two of us were at home. He would cry at night. He would not feed well. But we did, in spite of being pediatricians, we didn't understand that. And then things went on all. And a few years ago, Jayesh Anjali put a program on this same platform of a pediatric dentist from Mumbai. And she talked about tongue tie and its bad effect. And then we realized that this all had happened in our house.
Yes. Yes.
So at the age of 6 years, we got him corrected. The lesson I want to tell you is that we must ask for 100% correction. We should not say,
Yes.
थोड़ा सा tongue tie है तो चलता है ना हमको चलता है, but he suffers, no?
Okay. I'll say something here. I'm really sorry if I hurt anybody's sentiments here, but I see a lot of pediatricians not in favor of tongue tie release, and I have sat with them and talked at length. But then there are sometimes there are some very strong beliefs that you cannot talk ahead. So I try to be in the neutral zone where nobody gets hurt. But if you ask me, yes, if even if tongue tie is mild, you should get it treated.
So no,
So
I want to share with everybody that we must seek 100% correction. Like I have some heart attack, so I don't say I want only 25% correction. I need 100% correction. So every patient deserves 100% the best that we can offer. नहीं चलता है, we have a generally चलता है थोड़ा सा 15% तो defect है चलता है नहीं वो that is his life, no? So we need to. That's it. I was just trying to
yes,
share with
definitely. I completely agree. I
you.
completely
Yeah.
agree. All
I'm
tongue
your
tie
fan.
patients should be
I'm your
treated.
fan.
All mouth breathing patients, everything should be treated. And as early you go for the intervention, it becomes very easy for the child to cope up later.
True.
Breath is something, it is not only the child is going to take breath. Breath is something very, very nature, very existential need of any living organism. So if we can correct the breath, that is how I sleep so good at night. Because the kind of work I do.
After you finish, I have one more thing.
Yes, please.
Yesterday, a friend called from New York that the grandchild is snoring and they have asked for a 2-year baby, a small baby, for adenoidectomy. I said, you go ahead, because if the baby snores and doesn't breathe well, the baby's brain will not grow, body will not grow, intellect will suffer. And then today they called me to tell me the problem has disappeared. I said, if there is no fire, where are you putting the water on? They're taking a consultation, just sharing with you all how things happen, sort of.
Yeah, yes. That happens. And patients, I don't know why, but patients are not so in for adenoidectomy and tonsillectomy. I don't know why. But I do consult
They're
a
not
lot of patients.
ignorant. They're ignorant. They do not know it. So
Yeah, yes.
that
is there. Even when I have a lot of cases which
मराठी में
need
कहते हैं गधे ने गुड़ ही नहीं खाया तो उसको गुड़ का क्या मालूम पड़ेगा. So that's how we don't know what you are talking. So once you enlighten, we will do it. We're lucky to have you. I'm your fan.
Thanks a lot. It means a lot to me when you say this.
You're good. We're lucky to have
It's
you.
such a compliment for me.
Yes. You make Virar better place.
Oh my God.
We are thankful to your husband for bringing you here.
Yeah. Actually, I did not know where Virar is on the
Yes,
map
so
of India.
everything
But
is for good. He has done this good job, so everything else is forgiven to him.
Okay, okay.
Same
He's
is
a
valid
shy
for
guy.
Nilesh.
Yes, yes.
I think you and Dr. Soumil should be part of IP Palghar. We should add.
Oh, yes, definitely. See, I have always thought of working together with other specialities because that also increases our horizon. So I tell you something, orthodontics and endofacial orthopedics is a very proud branch. You would not find an orthodontist doing a lot of things. They're very, very proud. But working with Dr. Somil, I see so many cases and I see how much intervention can be done. So being with him has actually changed the way I used to see things. And whenever I meet another specialty, I understand that, oh, this is also something. This is also what we have to see. So I did during COVID, I did take a lot of ENT lectures. So I understood, oh, there is something so much to be seen in the nasal airways. There's so many things. So working together with different specialties always increases your horizon of understanding and thinking and how you would treat your own patients. So I would be more than honored to join IIP
Being
Palghar.
an member, Palghar
Yes.
Academy of Pediatric member. You
Sure,
and
ma'am.
Dr.
Let me know how to go about it, and we would be more
I'm
than happy to be a part of your.
Account झाले की तुमचे अवॉर्ड चालले जातील.
नाही
I would like
sir.
to request everyone if they can put their video on, and I can take a screenshot somehow. How
Yes.
is that done?
Everyone, please put your video on. We can also take a screenshot.
I don't know how it's done. I'll just take a second so that I can.
पृथ्वीताई माझं घर तुला दिलं. एकदा नेक्स्ट टाइम मिररला आले की आमच्याकडे ये.
I'm not able
Anjali?
to
Yeah.
scroll it through.
We will not be able to take up the epidemiology, so we
No,
take
no,
it
it's
for next
okay.
time.
Yeah. We
We will ask Pallavi madam to take screenshot of everyone.
Yes, yes.
Screenshot
Please.
anybody can take. You don't need it.
Pallavi madam, please take screenshot of everyone.
Pallavi, why everyone is not.
So, anybody can take screenshot. त्याला काय लागतं तुमच्या फोनला हलवला की झालं.
Yeah. So on this laptop, I'm not able to bring all.
Shubhra, are you sharing screen? No, na?
No, I'm not sharing screen. No, I have switched it off. Yeah.
So say cheese, everyone. Say
Cheese.
cheese.
I don't think. Now, get.
Yeah.
Yeah. Thanks a lot. Thanks a lot
you.
for
Thank
being
you.
such an amazing audience and letting me complete. I was rushing through the cases because I wanted to show you more. But thanks a lot for this opportunity.
And
I
thank
find
you,
it
Shruti, for
amazing.
being on the webinar for so long. So thank you, everyone.
Yeah. That was kind of a blessing for me that I wanted to see the growth things and I really wanted to know that because we also have a lot of patients and I've always wondered, yaar, ye itne chote hi hai kya? I did not know, but that is increased my knowledge. Thanks a lot, Dr. Shruti, for an amazing presence.
शुभ्रा आपके वो बड़ा बड़ा नाम अंग्रेजी में स्पेशलिटी का उसको एक बार हिंदी में बोल के बताएंगे ना तो समझ आप अगले बार फॉर द नेक्स्ट टाइम.
Yes, definitely. I'll find it out in Hindi. आपने मेरे को एक बार और पूछा हुआ है.
आप इतनी बड़ी होशियार हो इतना छोटा मोटा काम कर ही पाओगे.
Definitely, I'll do that.
I'd like to thank all the speakers of today, Dr. Soumya, Dr. Nilima, Dr. Shruti, Dr. Shubhra, our observer, Dr. Hemant Joshi, our senior pediatrician, Dr. Archana Joshi, our secretary Anuradha, who always gets us points for this webinar, and all those who have joined in today. I hope you all have enjoyed it as much as I have. So much of learning, and I've been in practice for over 40 years. So that's a lot of learning in one day. Yeah, Dr. Hemant.
If Anuradha doesn't come, the CMA becomes pointless. And nobody comes.
No, she ensures it's pointful before she comes. So regardless of whether she comes or not, she is very, very charitable and very benevolent to give us the points. So thank you, Anuradha, for all the efforts, and thank you everyone for joining in.
Yeah, the point is noted.
Thanks a lot. Thanks a lot.
Thank you. Thank you.